I am Amy Etzel. I'm the implementation manager with the BRIE Collaborative. We're so excited to have you here with us today and thankful to you for spending another big chunk of your time with us. Before we begin, just a few necessary required housekeeping announcements. NQUAC will accept attendance at this webinar session as a CE event. To receive credit, you need to document your time and submit a short survey. You'll receive an email later this week with a link to the survey along with a recording of today's presentation, relevant slides, and resources. Please remember that if you want a certificate for a credit, you must provide either your license number or an equivalent ID number. If you have questions about this, please contact NQUAC directly. Today's speakers declare no affiliation with or financial interest in a commercial organization that could pose a conflict of interest with the educational content of this program. We also want to thank you in advance for your patience and understanding for any technical issues we may experience. Last week went really well and very smooth. We hopefully will experience the same today. We have a few more moving parts and more people on panels, but hopefully everything will still go smoothly. We have another really exciting agenda today. The agenda is attached to the meeting invite that you received yesterday for your reference. We will start off with a quick informal conversation with two of the clinics I've been working with since January as part of the BRIE's Behavioral Health Integration Initiative on some of the work they've done around screening for social determinants of health and improvements around naloxone prescribing. We'll then hear from some clinical partners on the work they're doing. Jennifer O'Donnell, Clinical Program Director of Primary Care Integrated Behavioral Health at Swedish Hospital, will talk about SBIRT. And then Megan Muggleston, family nurse practitioner with NeighborCare Health, will talk about medication for opioid use disorder at the NeighborCare St. Vincent de Paul Aurora site. And then we'll hear from Julie Richards, Research Associate with Kaiser Permanente Washington Health Research Institute on suicide care. We'll open it up for questions on the presentations before taking a short break. And then after our break, we'll move into some group action planning around behavioral health integration. This is the section where we're going to ask for some grace. This ideally would have been a more engaging sort of roundtable type facilitated activity that we've tried to recreate in our new virtual Zoom world that will hopefully still feel meaningful and provide you with some new thoughts and ideas for your organization and the work that we're all currently doing. We'll be using the worksheet that's attached to the Outlook invite you received, so please have that handy and open and accessible after the break. And then finally, we'll have a panel discussion with representatives from our Medicaid managed care organizations and the Healthcare Authority, answering some questions received from that pilot group of clinics I work with around billing for behavioral health in a primary care setting, and then we'll have additional time to answer live questions. Again, asking for grace on that part, as a panel discussion with live Q&A is slightly tricky in our new virtual world. And then we'll hear some closing words from Jenny, our BRIE Collaborative Director. So again, we have a packed agenda and it was hard to get in enough breaks. We fully encourage you to get up and go to the bathroom, stretch, etc., while you're listening throughout the day. You are currently on mute and you will be throughout the day. During each presentation, please feel free to write a question into the Q&A box at the bottom of the screen. The meeting invitation also has Zoom instructions attached to it with detailed technical instructions about how to ask a question and what to do if you're experiencing technical issues. In short, please enter questions for our speakers into the Q&A box and any technical issues into the chat box. I'll be monitoring the Q&A box throughout the day, and then Alex Kushner, our tech guru, he'll be monitoring the chat box throughout the day should you have any technical issues. For our panelists and speakers, Alex will be promoting you in Zoom to co-panelist when your portion of the agenda comes. You'll automatically be on mute on your end, so please unmute yourself before you begin. He will then move you back to attendee status after your presentation, and you'll see a pop-up that makes it look like you're being kicked out of the summit, but you are not. You're just being moved back into an attendee status. Okay, so let's dive into our day. Before I hand it over to our collaborative chair, Hugh Straley, I wanted to start off, as I often do these days, with a little reflection. Last week, I started with a James Baldwin quote about welcoming in the work of facing change and truly seeing the things that need to change within ourselves and within our organizations. Please keep that openness and idea of expanded depth of knowledge as we dive into today's summit. And then I wanted to add in another idea based off of a podcast I heard last month. I spent a lot of late March and April listening to podcasts and attacking stubborn weeds in my very overgrown backyard. which is a really satisfying activity during a global pandemic when everything feels very much out of your control. One episode of Radiolab, which is a podcast out of WNYC, really has stuck with me and still continues to produce new thoughts for me. The concept was that the speaker came across a list from Cold War era America of items that a group of bureaucrats decided they would save in the event of a nuclear attack, and that they would use these items to sort of rally America as we started to rebuild. And the items were typically patriotic. It was a log from the USS Monitor, Lincoln's medical records after his assassination, signed Japanese surrender documents, and a map of Lewis and Clark journeys out west. He then decided to travel around and ask people what they would save and sort of bring this idea to the masses. And he started out by visiting some American Legion clubs and talking with veterans who offered up some similar patriotic items, Constitution, World War I and II artifacts. He then asked professors who offered up a lot of written word type documents like the Declaration of Independence. He then moved on to speaking to some museum curators and got some really good suggestions, less specifically patriotic and more about American identity, such as a recording of historical concerts like Mahalia Jackson at the 1958 Newport Jazz Festival. I love this idea of thinking about what would actually be useful and important enough to save and bring into whatever new world emerged out of such an attack. He then spoke with Arlo Ironcloud of the Lakota Nation, the communications manager and sometime radio host of KILI Radio, the community radio station serving the Pine Ridge Reservation in South Dakota. Arlo tossed around a few thoughts, but what he ultimately landed on is that he would likely save nothing, not even a pipe or treasures that have been passed down for over 800 years within his family and community. He said his community traditionally does not write stories down and believes that's a good thing. He said, the United States of America, the people that belong to it, sometimes I think they take the things that were written by your forefathers too literally, and they can't adapt it to the future. I've been thinking about this so much over the last few weeks, this idea of not being limited by what's been done in the past and really throwing out those limiting ideas to make way for new ones. I jokingly say to my friends that 2020 has no rules, and a part of me sort of means that. I think about this in terms of our work and the opportunities that such a terrible experience of a global pandemic can provide for us. We've already been innovative and produced some innovative changes in telehealth, as we heard about last week from the UW AIM Center and their partners, and creative solutions are emerging in other areas of healthcare in response to COVID-19. So I ask you to think about this as we approach our day and to think about letting go of the idea that some things just can't be changed. So let's try to dare to reimagine entirely and bring us into a new world of true integrated care. Okay, reflection time is over, and I will now turn it over to Hugh Straley, Chair of the BRIE Collaborative, to say a few words.
Oh, thank you. Thank you, Amy. And thank you for reminding us of change, which is happening all over. I want to welcome everyone again to day 2 of the summit that is really focused on behavioral health. I want to remind people about the history of the BRIE, which we reviewed last week. But the BRIE Collaborative has been established to humbly transform healthcare in the state of Washington. And I think we've done great work in developing over 20 work groups with recommendations that are taken up by the Healthcare Authority and then incorporated into their contracts for their beneficiaries of about 2.5 million people in the state of Washington. They're the largest healthcare purchaser in the state. And so we have great leverage. And for many of you, you know that the BRIE recommendations are also taken up by plans and hospitals. So this is work that we are very proud of, and we're proud that in our attempt to transform healthcare, we are seeing these kinds of implementation strategies developed. Behavioral health implementation is clearly one of the highest priorities, and as some have said, if delivery systems can achieve behavioral health integration, they can achieve improvement in so many other areas. So we have an exciting day today, and the end of the day, we'll look at action steps and how we can implement these changes, as Amy said, become the change that we can imagine. So I hope that all of you will stick with us in what has now become the new normal for meetings, Zooming, and we'll have a fruitful and productive day. So thank you very much for sticking with us.
Thanks, Hugh. So now we're going to do a quick spotlight on, actually first I am going to lock this poll, and then I'm going to move over to our next presentation. Give me just one moment. Technical issues. First, I just want to test, Rachel, are you here?
Hi, Amy. Can you hear me?
Yeah. Okay, perfect.
Right.
So I'm just going to start sharing what we're going to be talking about. So give me 1 second. There it is. Okay. I have to come back to my notes now. There's a lot of moving pieces on my screen, so give me just 1 second. Okay, so back in January, I started working with 11 primary care clinics around the state on a behavioral health integration initiative. And this group of clinics is our pilot group. Each clinic designated an internal team made up of a variety of roles within the clinic to work on this project. The teams completed a MEHAF assessment with me at that time to assess their current level of integration and help identify strengths and weaknesses within their current practice. They then designated 3 to 4 areas based on these gaps to focus on, creating what we call their 6-month action plan. The original intent of this project was to do a reassessment this month, having improved their scores throughout the work of their action plan. That timeline obviously has shifted with the emergence of COVID-19, but there's still some great work being done and currently being done and has been done despite the new challenges that COVID-19 has presented. So to share some of these successes, we're going to talk to 2 clinics. And we're going to start here with Rachel, Clinical Services Director of the Snoqualmie Ridge Medical Clinic, part of the Snoqualmie Valley Hospital Network, talking about the work they did and are doing around naloxone prescribing. Just as an FYI, this PowerPoint I have up on the screen is a presentation she gave to her team earlier in the year. We're not going to go through the whole presentation. She's just going to talk about the why and how they did this work and some of the outcomes. I'll be breezing through it visually just for reference, and then this will be shared out with the summit resources later in the week. All right, go ahead, Rachel.
Thank you, Amy. Good morning. My name is Rachel Robison. I'm a nurse practitioner and, as Amy said, the clinical practice director at Snoqualmie Valley Hospital Clinics. Can everyone hear me okay? Is volume okay?
Yes, perfect.
All right. I'm also serving as our team leader for the group collaborative pilot that we're involved with. One of our action goals after the initial assessment with Amy was increasing naloxone education and prescribing by our clinic providers to patients with the diagnosis of opioid use disorder. Our goal was to achieve a 20% increase. So our first intervention for this action plan was in February, and I presented to all of our clinic staff on naloxone co-prescribing for high-risk patients and their family members with access to opioids. Those in attendance were registration staff, medical assistants, nursing, clinic leadership, and 12 clinic providers, which comprised family practice, pediatrics, our specialty providers, including behavioral health and psychiatry. Some of the topics we had in that presentation were an intro to the CDC Prescription Awareness Project, and we also reviewed the Department of Health rules on when to prescribe naloxone and the differences between nurse practitioners' requirements and MDs. We also identified who is more at risk for opioid overdose, how to administer naloxone nasal spray, more at a peer level, and also how to help patients with administration, so they were aware of how to teach that. The talking points with patients was a big focus of this conversation. How to use destigmatizing terms and establish a safety plan with patients so that they understand the reasons why we're prescribing naloxone to them. We also ended with an open discussion within the clinic staff on what we can do as a clinic to improve our co-prescribing. One of the ideas that was brought up by the group was to build a health maintenance rule in our EHR, which would prompt both providers and clinic team to address naloxone for patients with a diagnosis of opioid dependence and chronic pain. And they'll also receive that reminder once they've actually prescribed naloxone. It will pop up at each visit after a year until it's addressed again. So we did implement that, and the things have gone quite well since we did the education with the complete group of clinics and added the reminder. So our intervention results since that session in February, we've seen a 120% increase in naloxone prescribed by our clinic providers in the last 4 months in comparison to the entire calendar year of 2019. So I attribute this significant increase in co-prescribing to the collaboration that is now occurring with all of our clinic team members to identify patients and families together who would benefit from naloxone education and prescriptions. So it's been the team effort that I think has really made this so successful for our group. Thank you.
That's so amazing, Rachel. Really, really great work. Thank you for sharing that story with us and for being willing to share the slides out with the audience later on this week. In the interest of time, if there are any questions for Rachel, please feel free to reach out to me after the summit and I can help put you in touch or answer any questions. Okay, next.
Yeah, I'd be happy to help.
Oh, yeah. Great, thank you. Next, we are going to talk to, sorry, I have a little bit of trouble with the sharing of the slides. Next, we're going to talk with Michelle Mathiasen, who is, Michelle, are you on the line?
I'm here.
Okay, great. I'm just trying to pull up your slide of, do you want to while I'm figuring this out, tell us a little bit about who you are in Kitsap Medical Group?
I do as soon as I can figure out how to fully unmute myself.
Oh, you're good. You're speaking. We can hear you.
Okay, you can hear me fine?
Mm-hmm.
Oh, thank you. So good morning. I'm Michelle Matheson. I'm a nurse and administrator with Kitsap Medical Group. We're an internal medicine clinic, as you can see on the slide there. We are private practice. We have 2 full-time doctors, part-time MD, and a PA that we just partnered with for behavioral health integration. And 3 offices. We are in all the nursing facilities, adult family homes, and assisted livings, and we also follow in the hospital.
Great. So Michelle was going to talk to us about a new social determinants of health screening tool that they have implemented into their annual wellness visits for Medicare patients. So why don't we start off with, Michelle, why did you decide to prioritize social determinants of health?
Right, thanks, Amy. So not necessarily a new tool per se, but we did implement the program. Back in January when Amy and I met, one of the things that we discovered was that we were lacking in working on our SDOH, and so we made a plan to implement that screening into our annual wellness visits, and there was a couple of reasons for that. One, to start out slow. We're a small clinic with small staff, and so we needed to be able to bite off something that we could chew. The other side of that is with the annual wellness visit, it will allow us to track in our system. We don't have a way to actually track SDOH right now within our EMR system, but by pulling annual wellness, we can then follow with the SDOH.
Great.
So we proceeded to make up policy and procedures. And Amy, do you want me just to go through the whole?
Yeah, if you're good with that, maybe talk a little bit about the workflow and how that has been incorporated in.
Yeah. So we came up with some policy and procedures and have implemented now doing the screening on our patients at their annual wellness visit. After the visit, at the time that this started, we were physically in the office, and I would come and review with the patient any screening tools that came out with a score level that was indicative of needing some assistance, especially in the safety arena. When we reviewed it with the patient in the office, we use Everyone Toolkit. I don't know if anybody's familiar with that, but it's a website that you can go to. You insert your zip code for where you are, and it will bring up all the different subjects that need to be reviewed, whether it's food, housing, transportation, safety, etc. And it'll hook the patient up with resources and referrals that they can access. And if the patient doesn't have access to internet at home, we would print out these referrals and resources with the phone numbers and provide those to the patient. And then from there, we would schedule a 6-week follow-up with the provider to review these things to try to make sure that we don't lose them in the cracks. I don't want to just send them off with their information and then not be able to follow up on them.
Absolutely.
And then COVID hit, and so now it's a whole different situation. But we had to take a little break there while we tried to figure out how to go remote, and then we have since started again. And at this time, we're using phone calls and exploring the option of using Zoom meetings to follow up with these patients and capture their needs and try to help provide their resources and referrals.
That's great. And so do you have a specific interval of time that you've developed in your policies and procedures around if they've answered yes and you've provided them with a resource?
It does depend on the person, and it depends on the answer. So safety is, we'll try to reach out via phone to capture these people for sure, at least with a touch by even myself calling or writing a letter. But we do a follow-up visit with the provider for 6 weeks.
That's great. Well, thank you so much, both Rachel and Michelle, for sharing the work you guys are doing, and more to come on this as we continue through the integration project. Now I'm going to turn it over to Jenny to introduce our next panelists. Just a quick reminder, we'll do a Q&A after all 3 panelists are done. So please be sure to enter in questions to the Q&A box as you think of them. I'll be watching these throughout the talks and jotting them down for when we reach our Q&A at the end. Okay, over to you, Jenny.
Thanks, Amy. So thank you all for being here with us this morning and really seeing all those reactions to 2020 thus far. And I really can't believe that it's only half over. It feels like it's been so much longer than 6.5 months. I really think about our shared experience of stress, anxiety, this added confusion that we are all feeling, and thinking about how behavioral health integration is really this acknowledgement of the fact that we have a mind and we have a body, and that both of these really contribute to our overall health. So I'm honored today to introduce you to our panel, who will do kind of a deep dive into our screening, brief intervention, referral to treatment, recommendations, treating opioid use disorder, and suicide care. So Jennifer O'Donnell is a licensed clinical psychologist serving as the clinical program director for primary care behavioral health at Swedish Medical Group. She has a passion for integration of services to treat the whole person and moving away from the fragmented care of our mind and body. She hopes to see communities move to a point where there's no stigma around receiving mental health treatment, and that anyone who wants to receive mental health treatment really can. Jenny received her BA from Virginia Polytechnic Institute and State University and her MA and PsyD from Radford University. Megan Muggleston is a family nurse practitioner working for Neighbor Care Health. In addition to seeing patients in the primary care setting, she serves as Neighbor Care Suboxone Clinical Champion, a role designed to increase the number of waivered providers in the organization and offer training and support to clinical staff related to medication for the management of opioid use disorder. Prior to working for Neighbor Care, Megan was a captain in the U.S. Army and worked as a nurse in this capacity in Washington, Texas, Indonesia, and Afghanistan across 9 years of service. Megan earned her BSN from the University of Washington and her MSN from the University of Texas. And Julia Richards is a suicide prevention researcher and was a key part of our BRIE Collaborative Suicide Care Work Group. She currently leads a project at Kaiser Permanente, Washington, that's focused on patient-centered approaches to addressing firearm-related suicide risk, and works with researchers at other large healthcare systems to evaluate effectiveness of the zero suicide model, as well as a large pragmatic trial of population-based programs to prevent suicide attempts and deaths. Julie received her BA from Columbia University and her MPH and PhD from the University of Washington School of Public Health. So thank you all three, and I will turn this over to Jennifer O'Donnell.
Good morning, everybody. Welcome, and yeah, I guess this is a new normal in terms of how we connect with each other. So today I wanted to spend about 20 minutes talking about SBIRT and our move to universal screening and kind of what that has looked like for us at Swedish. So just to the next slide, talking about kind of what we're going to focus on during this time.
Sorry, I'm working
Quite
on
all right.
There it is. Okay.
So just going to start by kind of laying the groundwork of what is SBIRT, just in case everybody here is not familiar with SBIRT, and then talk a little bit more specifically about the screening and the brief intervention and kind of what that looked like within our clinic settings. And then going to switch gears a little bit and talk about some of the challenges and the lessons that we learned within our program, as well as highlight the benefits and the wins. Like, why did we do this work? And then talk a little bit about kind of where we are now, where our current state is. So next slide. So what is SBIRT? So SBIRT is a universal public health approach to integrating behavioral and primary health care. It's a way to increase awareness that substance abuse is preventable and that treatment works. SBIRT can be provided in any variety of settings, and really is focused on that universal screening, detecting risky or hazardous substance use that may lead to abuse or dependence, and really focusing on that early intervention, that we are not making assumptions about who might be at risk or what else might be going on, that we're just asking everybody, and that it gives us an opportunity to have a conversation instead of having people self-identify. Next slide. So again, SBIRT is really focused on reducing substance use, abuse, and dependency, as this can absolutely improve health outcomes. And it can decrease risk for injury and negative life consequences. I think that this group of individuals here on the training today, no one would argue against the idea that early intervention is key. One of the pieces that is important to healthcare systems and can help support implementation is that SBIRT is a protocol that helps to decrease healthcare utilization, which then decreases healthcare costs and the cost to the system and patients around management of chronic health conditions. So from a population health perspective, this is absolutely a beneficial opportunity for decreasing that healthcare utilization cost. And SBIRT really does fall back on and utilize motivational interviewing. This is the clinical approach. So once you've done the screening, then you really have to have a strong foundation in motivational interviewing in order to truly connect with the patient in a non-judgmental way. And that approach, that way of being with our patients can really help us to address the substance use disorder and other chronic health conditions to support an individual making a positive health change. Next slide. So at Swedish, this was actually back in 2015, 2016, that we were part of an SBIRT grant through the state. And we focused on 2 of our primary care clinics that we were just integrating behavioral health into. So this SBIRT protocol lined up at the same time as our primary care behavioral health integration. So the way that we did this was we combined it with a universal depression screening. So we really wanted to ensure that we understood the full picture. So we created a behavioral health wellness screening that we utilized at annual wellness visits for all adults 18 and above. And the brief intervention was then conducted by the PCP and or via a warm handoff with the behavioral health provider. So depending on the level of risk and where things were at, the PCP could have that low risk conversation or would refer to the behavioral health provider, who would then move forward with a more in-depth intervention. Next slide. So this is the screening form that we utilized. And again, what we would do is any patient that was coming in for an annual wellness visit that was 18 or above, so this included our Medicare patients, we would give them this screening form. And as you can see, the first two questions are the PHQ-2. And whenever that was a positive score, so on this you can see that we used a score of 2, we have shifted to a score of 3. But once there's a score of 2, we would then ask the patient to complete the full PHQ-9 and the GAD-7 so that we could also capture any anxiety that might be going on. So that was the first part of the form. And then we would ask the question of, are you in recovery from or currently in treatment for alcohol or substance use? If yes, so if they're currently in recovery or currently in treatment, we stopped. They did not need to be screened further. They were already in the treatment that they needed. If they said no, then we asked them 2 more questions. We asked them a question around binge drinking. So how many times in the past year have you had 4 or more drinks in a day? And any positive response, so even if they only had 1, did prompt the full audit. And the second question was, how many times in the past year have you used a recreational drug or a prescription medication for non-medical reasons? And again, a positive response resulted in them being asked to complete the full DAST. Now, one of the things that we did find was that, marijuana was something that definitely fell into the second category and prompted a lot of positive DAST. And there were definitely some mixed emotions around that one. And I'll talk a little bit more about that here in a minute. So the next couple slides are just showing you the full screen. So this slide is just a recapture of what the PHQ-9 looks like, as well as what the GAD-7 looks like. And then the next slide is the audit and the DAST. So just making sure you guys have these for reference. Now, when those screenings were scored, so those were administered by the medical assistant. So the front desk would hand the screening form, and the patient would bring that back. Once the patient had seen that they were positive, then the MA would give the full screening. So we had a separate colored form that had the PHQ and the GAD on one side and the audit and the DAST on the other. So they would give that full form to the patient and indicate which of the measures they needed to complete. And they would work on that while they waited for their PCP to come into the room. When the PCP came into the room, they would have been alerted that the patient had screened positive. And so they would come into the room and immediately look for that bright yellow sheet. And we found that having that colored paper for the initial screening versus the full screening, that really helped from a visual standpoint to raise awareness for the PCP when they walked in the room. So if for some reason they missed their medical assistant, they would still come in the room and see this bright colored paper that would trigger them to say, oh, they had a positive screen, I need to take a look at this. The scoring is really quick and easy, so it really allowed for the PCP to do a quick glance and score it right there. We also had all of the PHQ, GAD, audit, and DAS built into our EMR. So the PCP could also transcribe those into the EMR and it would score it for them. So this was a card that we placed in every single room. And this was, again, another tool that's been developed through the SBIRT protocols, particularly with the primary care integration protocol, to facilitate those conversations. So this was one way that the PCP could kind of quickly remember which category people might be in, as well as reminding them of how to go through that brief intervention if they did not utilize the behavioral health provider. We definitely found that there was a lot of power in sharing the statistics, letting people see visually where they fall, that, you know, when they are thinking about their group, their normative data, they're like, well, you know, I drink less than my friend, but when they see it against some of these larger data sets and see that maybe they're falling into category 2 of risky behavior or even category 3 of harmful, that was really a powerful moment with patients. That did not take a significant amount of time. It didn't take any browbeating them over the head. It was simply presenting them with some data and letting them kind of decide what made the most sense for them. Next slide. So as I mentioned, this was rolled out alongside our behavioral health integration in those clinics. And really what we found was that we tried to, whenever possible, a positive screen was immediately connected to the behavioral health provider via a warm handoff for that brief intervention. So basically we had, each clinic was a little different, but the behavioral health provider carries a pager. So no matter where they are in the clinic, the MA could page the behavioral health provider, say, room 7, positive SBIRT, and we would immediately come to that room. And as soon as the PCP was finished with their part of the visit, we would go in and discuss the results of their screening and engage in that brief intervention. We found that combining the PHQ, GAD-7 with the substance use screening really allowed us to have that more immediate, comprehensive picture of what the patient was experiencing and where we may want to focus some of our efforts. So it definitely allowed us to have that more holistic picture of the patient. And so I highly recommend, you know, including both the mental health and the substance use screenings together. It's not that much extra work. So if you're already screening, might as well do both and get the full picture. We also found that having that opportunity to and encouraging that same day handoff increased engagement. If, say, I as the behavioral health provider was out of clinic that day, I had a really hard time connecting with patients the next day or 2 days later in order to really focus on this brief intervention, trying to do it by phone or trying to get them to come back into the clinic. So when I was able to talk with patients that same day while they're already there in the clinic, patients were much more receptive to having that conversation and having that brief intervention. So we found that that really made a huge difference. Again, focusing on that motivational interviewing style and non-judgmental conversation. So really being willing to let the patient be an autonomous person and make choices. So we're giving information and we're trying to see where they may be able and willing to make a change. I also found, and you know, this is in the research as well, that focusing on a change that the patient is driving, what makes sense to them. So based off of the information that they're provided, where's their readiness? What might they be willing to do? So while the PCP might have had the goal of abstinence, being able to have a conversation about reduced use. Okay, maybe we cut back, 1 day a week, or by 2 beers, or, whatever it might be. Coming into alignment with the patient on what they're able and willing to do can build their confidence and can help move them towards the ultimate goal of improving their health. We offered follow-up with the BHP as needed. And then for patients that were higher risk or that needed a higher level of care, the behavioral health provider would work really closely with that patient to help them get set up for next day assessments. Through the grant, we had some reserved spots to help with next day admission as needed. And that was, again, essential, that we really sat and helped with that potential referral, rather than just giving the patient the information and saying, here you go, let us know how it works. So really coming alongside and working with them. And then the BHP would follow up with that patient a couple of days later to make sure that they made it to the appointment and to help with any follow-up that might be needed. The last thing I'm going to emphasize with the behavioral health provider that was really essential was that we have a shared medical record. Our behavioral health records are within the primary care and system records. They are not separated out. There's no additional security measures that require you to indicate why you're going into that record. So we were really building an integrated service, and that helped to ensure that the PCP and the entire continuum of the care team were aware of what we were doing and how we were working together to meet the needs of the patients. And that has, across the board, been a really key component for us. So the next slide reviews just how to do a brief intervention. I'm not going to spend a lot of time on this. We've talked a little bit already, but really focusing on raising the subject, building that rapport, asking permission. Asking permission to discuss the person's substance use can go a long way. Providing feedback, really using the readiness ruler to enhance motivation, and again, negotiating a plan and asking them what they think they're going to do. So letting the patient drive that change. And this intervention is generally no more than 10 minutes. So it does not have to be a full 30-minute behavioral health brief visit. We often did this within 10 minutes because we knew exactly what we were going in and talking about. So thinking about some of our challenges on the next slide, reimbursement varied. So in the grant, we didn't have to worry about reimbursement. We told patients that it was part of a grant and that they would not be seeing a bill. And so we did drop charges to track things, but they were covered through the grant. But when the grant ended and we did start to bill, we found that was often a barrier to patients being willing to engage in the conversation. Not sure how that billing would pan out, and inconsistent coverage. The other piece that, again, the grant allowed us, but is really challenging for sustainability, is ensuring that all of the PCPs and staff are appropriately trained in the SBIRT protocols. So really trying to take PCPs out of clinic for a 4+ hour training can be a challenge if there's any turnover. We also found that PCP buy-in was somewhat dependent on the behavioral health provider being available. So when we were in clinic, they were really ready and willing to do the screening, but buy-in could sometimes be a little less when that behavioral health provider was not readily available and they felt that they would have to be the ones to do more of that intervention, which, put them behind and made it harder for them to stay on time throughout their day. So having that partnership with the behavioral health provider was essential. We also ran into a lot of workflow issues due to staff turnover. Every time a new staff came in, they would forget to give the form or anything that was different for one type of patient visit. really seemed to start shifting things. So that was a constant training piece. But having that automated within the EMR and having some prompts was definitely something that has helped us since then. And then marijuana, again, depending on the PCP that you were working with, depending on, a number of factors, with marijuana becoming legal, that was a challenge for us, trying to think about how to best address that. And again, they screened positive, we would go through the process, and most of the time it was really falling back on those motivational interviewing skills and reviewing what are the things that we can do, and just giving them information, letting them make their own choices. Next slide. I recognize time is getting a little short, so I'm going to rush through these last two.
Don't rush too much. You're fine, Jenny. I think
Okay.
we built in a little bit more than we needed to for the Q&A, so go for it.
All right, thank you. So the benefits and the wins. We had repeated examples of patients being identified as at risk who might not have otherwise discussed with the PCP. Even a patient that I had been working with as the behavioral health provider, we were really focusing on a lot of their health conditions, and for whatever reason, going through the screening process, they were more honest about the amount that they were drinking. And then we were able to start making some connections back to how they were struggling with their chronic health conditions. PCPs noted over and over again that they'd been working with patients for, a really long time and had no idea that they were, drinking 3 or 4 drinks a night, or that they were, smoking marijuana, or that they were taking some prescription pills that were not theirs. So it really did create an opportunity for patients to connect with their PCPs and be a little bit more honest about what was going on for them. We found that universal screening, so when it became something that we were doing for every patient, that alleviated a little bit. Prior to implementing the SBIRT protocols, it would sometimes feel like the PCP would ask those substance questions when they thought they needed to ask, when they were trying to piece things together. And it was not a systematic, we just ask everybody this because it helps us have a better picture of your full health. So that helped to decrease some of the stigma, that when we could say, oh, we ask every patient this at least once a year, that reduced people's anxiety about that. We also found that it was a great opportunity for student behavioral health providers to engage and enhance their skills around motivational interviewing without an additional cost to the patient. So as we moved out of our grant, some of our students actually continued to receive grants through the University of Washington and their SBIRT grant. And so they focused on providing those services. So whenever there was a positive screen, the warm handoff was conducted by the student, which really helped us to focus on reducing that financial cost to the patients, which was one of our major, and continues to be one of our major barriers. So current state, so the final slide I have, is that in the clinics where we did this grant, we do not have a formal SBIRT protocol anymore. It's unintentionally faded due to administrative support at the clinic level. We had an EMR update. We had some shifting in the behavioral health resources at that clinic. There were just a lot of changes all happening at once, and the SBIRT protocol was just unfortunately one of those things that started to fall off. However, right before the COVID crisis, our system was revisiting these workflows because we actually had a couple of the PCPs that had been involved in the initial trial that kind of messaged me and go, we used to do this. Why don't we do this anymore? I feel like I'm missing so much. in terms of that screening opportunity for my patients, and can I start doing that again? How do I do that? So we have started to reintroduce it at those clinics, but again, with the COVID crisis and moving to virtual, we hit another stumbling block, but are hoping to really kind of revisit how we do this and ensure that we're able to accurately and consistently screen our patients. The thing that did stick and has been a major win for us is that we do universal depression screening. So that PHQ-2 is now integrated into our EMR as a vital sign. So whenever a patient is being roomed, just as they're having their temperature and their blood pressure checked, they are prompted to be asked the PHQ-2. And then when positive, they would get the full PHQ-9. We initially, again, this was something that was only being done at annual visits, but not everybody comes in for an annual visit. And then, you have to remember to catch it. And then there's also, well, what if they haven't come in for it every year? So we really shifted to focus on every patient, every visit. The PHQ-2 in and of itself is not a long screening. So we just really emphasized every patient, every visit, because depression especially is something that is not going to only be captured once a year. Same with the substance use questions. I think if we can, and we're going to look at how we integrate that into the EMR as more of a, standardized practice, my hope is that we will be able to more fully capture and address these concerns with patients when they need it, rather than waiting for them to address it with us, or for that one time a year when we may more intentionally ask those questions. So with the virtual visits, we are looking to start automating the assignment of PHQ-2, so that whenever a patient is coming for a virtual visit, if they're overdue for a depression screening, they will get a prompt to complete those questionnaires prior to their visit. So using the technology, we are really hopeful that we're going to have some opportunities to send these screenings out to patients in advance and better prepare the agenda for their appointments and ensure that they have connection to a behavioral health provider, that they have connection to the resources that they need. So lots to unpack. There's, so many different things, but I would just continue to highlight that SBIRT protocol really did help us to catch those patients that were in that level 2 or 3 risk category, but weren't having consequences yet, and really start to help them make some changes before there were significant consequences. So it's a really powerful tool. It's, again, not too difficult to implement following training, but you do need some of that administrative support to ensure that the screenings get handed out. So I will pass it over to our next presenter and look forward to answering your questions during the panel.
Thank you, Jenny. This is Ginny, and I really appreciate your coming and talking with us today. And I'll also take this as an opportunity to encourage everyone to join us tomorrow for our webinar on motivational interviewing and SBIRT. We've heard again and again, this is a very difficult skill, and so wanted to spend some dedicated time thinking through how best to do this. So now I have the pleasure of turning our virtual stage over to Megan, and again, thank you for joining us today.
Yeah, thanks so much. Thanks for the introduction. So I'm Megan McGillesson, and I'm a nurse practitioner with NeighborCare Health. And like was mentioned in my bio, a part of my time is dedicated to helping make our buprenorphine program a little bit more robust at NeighborCare and supporting all of the staff that are kind of engaged in that care. Let's see here. Okay, perfect. So I'm going to talk through a little bit about our experience at NeighborCare with rolling out a buprenorphine program, and a little bit about things that have kind of helped us along that journey. Going to the next slide, please. But I'm going to start by addressing kind of the nature of the issue, and then we'll talk a little bit about the treatments that are available. So the opioid epidemic, in case anyone forgot that this is still an issue, even though we're in the midst of a pandemic, it very much is. Really, it grew out of a variety of factors, but notable among these were the false conception that was pushed by pharmaceutical manufacturers that opioids were safe and unlikely to cause addiction, that kind of coupled with a national push to treat pain as the fifth vital sign and a marker of patient satisfaction on surveys, such as those used by Centers for Medicare and Medicaid Services. What we know now is that roughly a quarter of patients prescribed opioids for chronic pain misuse these medications, and around 10% will develop an opioid use disorder. And a portion of those prescribed opioids will go on to use heroin. This has culminated in an alarmingly high number of fatal overdoses. In 2018, there were about 46,000 such deaths. And when you compare this to 36,000 traffic deaths in the same year, you get a sense of the scope of the problem. Over the last 2 decades, primary care providers have increasingly become involved in treating OUD, following the Drug Addiction and Treatment Act of 2000 and the approval of buprenorphine in 2002 to be used for OUD in the primary care setting. It's important to understand that there are still barriers to the widespread prescribing of buprenorphine, not least of which is the requirement for 8 hours of training for NDs and DOs and 24 hours for advanced practice providers in order to apply for a waiver that has a cap on the number of patients that a prescriber can treat. And I always think it's interesting to compare kind of the restrictions around buprenorphine with kind of the relative ease with which prescribers can prescribe for other opioid medications. Go ahead to the next slide, please.
Megan, we're getting feedback that it's a tiny bit hard to hear you, so maybe if you could talk a little bit closer to the microphone, that might be helpful.
Sure, I'm using Bluetooth. Maybe if I try.
Okay, even you just being a little bit closer is helpful, right? Just in that last bit that you spoke. Are you still with us, Megan?
I am, yeah. How is that? Can you hear me better?
That is better. Thank you so much.
Great. Okay, so on this slide, this is a look at overdose death rates per county per 100,000 individuals in Washington. You can see that overdoses are a significant problem kind of all along the I-5 corridor and interestingly out on the peninsula where we see some of the highest rates, which also correlates with decreased access to treatment. Anecdotally, I work in North Seattle and I see a number of patients that come down from Snohomish County where rates are quite high as well because they don't have access closer to home for treatment. Next slide. So the good news is there are effective treatments for opioid use disorder. The primary tool that we use at NeighborCare is Suboxone, which is the brand name for the combination product buprenorphine naloxone. The buprenorphine is a partial opioid agonist that targets the same receptors as full opioid agonists, but with less activation of the mu receptors. And the upshot of this is basically a product that can eliminate withdrawal symptoms and subjective cravings that patients go through, but with less of the euphoria, less risk for respiratory depression, and tolerance than in its full agonist counterparts. When Suboxone is taken sublingually, as it's designed to be taken, the naloxone component has very limited bioavailability, and if it's injected or snorted, it acts as a full antagonist. So it's basically present to help prevent diversion of the medication. Next slide. So this slide kind of gives a quick snapshot of the bottom line benefits of treatment for opioid use disorder, and that's in a decrease in all-cause mortality. So this is comparing kind of a general population, the standardized mortality ratio, to folks that have opioid use disorder that don't receive any form of treatment, compared with those that do receive a medication form of treatment, such as buprenorphine, naltrexone, or methadone. And you can see that by being on a form of medication treatment, we're reducing that mortality ratio a lot more closely to kind of the standard of the general population. And so all other things being equal in primary care, anytime that we can help reduce risk for mortality, we take that as a win. Next slide. So I'm gonna walk through a case study from one of our patients here at Neighbor Care. And Amy, the next couple of slides, there are like several elements to each of the slides, so you can just kind of click through the slide as I'm talking. Perfect. So this is Dana. She's a 33-year-old CNA, struggling to work full-time, care for 2 kids, and manage smoking heroin daily. She started using marijuana as a teenager in high school, and then ended up getting a prolonged oxycodone prescription after 2 surgeries at the age of 18 and 20. Go ahead and click again on the slide, Amy. Good, one more time. And what she tells you is that she just felt like her doctor was prescribing the oxycodone for way too long. She ended up starting to snort the oxys occasionally until she got pregnant and was able to quit with abstinence-only groups at that time, which is a pretty rare finding for most patients. She did fine for 9 months until postpartum depression hit, and she began snorting oxycodone again, which helped until it went to daily use. Go ahead, a couple more clicks. Okay. She got pregnant again and got on methadone maintenance, which is a great treatment. And for over a year, this worked well for her, and she tapered off, was able to get sober until kind of the next major life stressor that happened. Her dad was diagnosed with stage 4 lung cancer, and she cared for him on hospice. With grief and ready access to opioids, she relapsed to smoking or snorting pills. After he died, the money was getting low and heroin was a lot cheaper for her to purchase, so she started smoking instead of snorting pills. She began to buy Suboxone illicitly to help her feel normal, but she can't find enough of it to stay well and uses heroin still. So this is the point at which she came to Neighbor Care for help, and she was started on buprenorphine at that time. Go ahead, a couple more clicks. And go ahead and keep going. These slides are a little bit tricky. Okay, and so at this point today, she's been on buprenorphine for several years. She's drug-free, she's employed, and she is staying with her family. So in this example, we can see that addiction is a treatable chronic condition. And I think one kind of paradigm shift in primary care is to view substance use disorders kind of through a similar lens that we view things like chronic diabetes management or chronic hypertension. Next slide. So one of the main things that I think a lot of our providers at Neighbor Care have discovered kind of in this journey of treating opioid use disorder is that addiction is a treatable chronic illness and something that really is within the wheelhouse of a primary care provider to help manage. It's something we should be screening for in primary care. I really like kind of the tie-in with SBIRT for this because it's something we can treat. Things that we should be looking for in patients that have substance use disorders are things like escalating use over time, use despite harm, use taking up life activities, multiple unsuccessful attempts to quit or cut down, and development of tolerance or dependence. Next slide. So why should opioid use disorder be a regular part of primary care practice? Well, with only about 3,000 addiction medicine specialists and 8,300 psychiatrists currently waivered to prescribe buprenorphine, there would be a massive lack of access to care for the estimated 2.4 million Americans that have an opioid use disorder. So if we can kind of leverage the 320,000 primary care providers, that is a large means to be able to address the shortage of opioid use disorder treatment. Next slide. And we do see that more and more providers are getting waivered. Here's a look at physicians with a waiver from 2002 to 2018. Also, just to point out that under the Comprehensive Addiction and Recovery Act of 2016, advanced practice providers are also eligible to become waiver prescribers as well. I got my waiver in 2017, so just a year after kind of the rollout of the CARA of 2016. And that's another really great means of being able to increase access for folks that need this treatment. Next slide. Okay, so NeighborCare's journey with buprenorphine started in 2014. That was when our first physician became waivered to prescribe Suboxone. In 2019, we received a HRSA grant to select several clinical staff, myself included, to act as medication for opioid use disorder clinical champions. And this is in an effort to help increase the number of waiver providers and to offer support to staff engaged in providing this type of care. Today, we're offering low barrier access to medication for opioid use disorder at nearly every primary care site, and expect that by the end of this year, we will be offering it at every primary care site. Next slide. So this is a look at our kind of steady increase in waiver prescribers, specifically at NeighborCare. I believe this end number of 34 is probably closer to 40 at this time, as we've continued to have a handful of waiver prescribers kind of be turned out in the last 6 months or so. Next slide. And probably no surprise, as our number of waiver providers has increased, so too has the number of patients being treated. And really for us, that's what this is all about. There's a large need for it in King County and in the surrounding area. And so as we're able to increase the number of folks that can write for this type of medication, we're able to touch more lives that are in need of it. Okay, next slide. So after the first clinic that kind of rolled out a buprenorphine program, had things set up for a while, they decided to take a survey of staff that were working there to see kind of what the experience was like for them. Initially, there was some concern about whether treating opioid use disorder in a primary care setting would negatively change the clinic experience. And the staff survey showed that for the most part, most people felt like things hadn't really changed very much to their notice. It was pretty much status quo. Taking on more opioid use disorder patients just sort of melded in with the general patient population and wasn't a noticeable change. And interestingly, there was a group of staff that felt as though this was a change for the better to have this type of care provided at the clinic. And also interesting to note that none of the staff that were surveyed reported that they felt that there were changes for the worse in clinic flow or in clinic culture. Next slide. Okay, so the next few slides are going to go over some of the actions we've taken at NeighborCare that have helped to make our program successful. A couple of key elements have been training our medical assistants and nurses. We've worked to train all of our MAs on accessing the prescription monitoring program and how to read a urine toxicology cup. We've also implemented a buprenorphine authorization protocol that can be used at the prescriber's discretion, which allows established patients to be seen by a clinic nurse or behavioral health counselor in order to get a refill of their medicines. This has been hugely helpful for increasing access to buprenorphine, particularly for patients who might walk in after missing a visit and may otherwise not get a chance to see their provider to get a refill because the provider schedule is too busy for that day. Within the buprenorphine authorization protocol, we kind of have it broken down into two elements. So there's a continuation protocol, and this is for patients that have missed a visit by 3 days or less. And in this situation, the nurse or behavioral health counselor basically has the ability to write for a similar length of prescription as what the patient was previously receiving. There's also a re-engage protocol, and this one I think is especially helpful. This is for patients that may have missed a visit by up to 60 days, and it allows for an RN or behavioral health counselor to basically write a bridge prescription for no more than a few days in order to allow that patient to be able to get in to see a waivered prescriber. But we know that anytime that we can kind of get patients back on Suboxone, we're helping to lower that mortality risk. It's also kind of helping to break that cycle of withdrawal and craving. And so basically as quickly as we can get someone back on that medication, we've seen benefit with that. And using this buprenorphine authorization protocol has made large strides in that direction. Next slide. We've also found that providing easy access to consultation from more experienced providers has really increased new prescribers' comfort with taking on this work. We have an addiction medicine email box, and we also have a chronic pain and opioid consults email box. We found that sometimes those two categories can kind of overlap, and so it's nice to have providers that feel really comfortable and experienced for both of those issues that can help field questions. We've also created a number of resources on a shared drive that answer a lot of the questions that are kind of most typical for clinical staff, and also there's resources there for providers, nurses, and counselors. And then also in the last year, we've used grant funding to focus on training for new prescribers of Suboxone for the nurses, counselors, and MAs that may be involved in OUD care. And through this funding, we've also been able to offer the ability to shadow new prescribers as they see Suboxone patients if they desire that, or to provide phone support for those new prescribers. Next slide. So this is a quick look at our shared drive and some of the resources that we have available there. We've included paperwork for intake visits, resources on treatment locations in the Seattle area, educational handouts for families, patient instructions on how to start buprenorphine. We also have a clinical treatment guide on this page that walks prescribers through many aspects of buprenorphine visits. If there's any resources that would be useful for your organization, please feel free to email me and I can pass along anything that you're interested in, take a closer look at. Next slide. So we know that opioid use disorder is a significant issue for people experiencing homelessness in King County. In 2018, those experiencing homelessness made up less than 1% of the total King County population, but they accounted for 16% of its opioid-related deaths. Data from the King County Needle Exchange sites from 2017 showed that 78% of those who responded to a survey voiced an interest in reducing or stopping opioid use. So we know that the desire is certainly out there, and we know that it's an issue that disproportionately affects those that are experiencing homelessness. And so to that end, Neighbor Care offers medication for opioid use disorder at kind of all of our sites that most often have touches with people experiencing homelessness. So this includes our Ballard Clinic that's specifically for those experiencing homelessness or living in supportive housing, our Evening Youth Clinic for those under 26 experiencing homelessness, a clinic embedded in the REACH case management office, although to be fair, this one right now is closed because the REACH case management is currently closed due to COVID, but we hope it'll be able to reopen in the near future. And we also have nurses that are doing outreach at encampments and permanent supportive housing to help coordinate medical care and connect folks with care for OUD. And that work is still ongoing despite COVID. Next slide, please. So I would be remiss if I didn't address kind of the current state of care as it relates to COVID. With the suspension of the Ryan-Haight Act and new insurance rules allowing reimbursement for telephone visits, we've been able to transition to buprenorphine care mostly by phone. And this includes intake for new patients that we've never seen in clinic before. And for those that don't have access to phones, we are still seeing folks in clinic, just following social distancing guidelines. Really, our hope is to ensure that this service remains widely accessible for our patients, even kind of amidst the global pandemic, and to not lose sight of the fact that the opioid epidemic is not taking a break during this time. Next slide. So kind of a lessons learned for us has been that we found that it takes time to get full buy-in on an approach that attempts to reduce barriers and prioritize quick access to buprenorphine. We know that there's ample evidence, and it's been really helpful to kind of share this with our staff to support this approach. And we will often point out the relative safety of buprenorphine when compared with other opioids, to include that in overdose death autopsies, buprenorphine is only found in 1 to 2% of patient systems. And we also try to teach providers to have an expectation that relapses, although they're reduced with treatments such as methadone or Suboxone, are still somewhat common, as high as 30%. And this should be normalized when patients go through kind of this step of the recovery process as part of their overall treatment. We also try to make sure that providers understand that relapses shouldn't be a disqualifier for continued treatment. Additionally, it's been really helpful for providers to have an understanding that patients with polysubstance use can still find success with buprenorphine for opioid reduction or cessation, because it's important for patients to kind of have that support from providers, and important for providers to understand that buprenorphine is really only designed to help manage the opioid use disorder and other types of substance use disorders. Although there may be some kind of benefits from addressing that opioid use disorder, need to be addressed in other ways, but that things like methamphetamine use, marijuana use, cocaine use shouldn't preclude the continued use of buprenorphine for patients that are finding success with that medication in terms of their opioid use. Next slide. Okay, so this slide shows relapses during treatment among Mass Health members from 2003 to 2010. The green line is showing a group that received abstinence-only support. The blue line is showing patients that were being treated with buprenorphine, and the red line shows patients that were being treated with methadone. So simply put, relapses were significantly reduced in both the buprenorphine and methadone treatment groups as compared to a group receiving abstinence-only support. So again, just kind of more support for the work that we're doing with buprenorphine and the ability to decrease the number of relapses by using this form of treatment, and knowing that anytime we can keep patients on these medications, we're lowering their risk for all-cause mortality. Next slide, please. Okay, so this is one more case study to share. This is Sarah, another neighbor care patient. She's a 21-year-old woman with a history of PTSD, and she's been smoking heroin daily for about a year. She failed out of professional school. She's been unemployed for 2 years. She's treatment naive, has never attempted any type of group therapy or any type of medication treatment for opioid use disorder. She started using drugs in high school, beginning with marijuana, then kind of transitioned to prescription opioids and now heroin. She's currently living with a physically abusive boyfriend, and she also reports that she's dabbled in other drugs, but her main drug of choice is heroin. Next slide, please. Okay, so this chart is looking at Sarah's urine toxicology results over the first year of treatment. You can see that it kind of took a few weeks for her to stop using heroin, but that as she began to stabilize on buprenorphine, she was able to address significant factors in her overall well-being. She broke up with her abusive boyfriend. She enrolled in therapy at 8 weeks. She received preventive care during the course of her treatment. She got a job, quit smoking cigarettes, and enrolled in college. And to me, this is the power of medication for opioid use disorder. By helping patients to kind of get out of that cycle of withdrawal and cravings, they're able to focus on other aspects of their life and well-being. And I find that this work is pretty easy to do, similarly to care for patients that have other chronic conditions that we routinely manage in primary care. And there's a huge need to increase this type of treatment. It's also hugely rewarding to see patients like Sarah who are able to make such kind of massive changes toward improving their quality of life. Next slide, please. Okay, yeah, so this was a message down there at the bottom that the clinic received a time later after Sarah was tapered off and stopped therapy, just saying that she came back in to let the provider know that she had graduated and got a license in massage therapy and had been opioid free for 2 years. And so just sort of how fulfilling is it to make that big of a difference in someone's life that can be the difference between life and death. And those success stories are, I think, the reason why a lot of us have gone into healthcare is to see things like this happen. And it's something that can be pretty frequent in taking on medication for opioid use disorder. Okay, next slide. So our experience at Neighbor Care has been that opioid use treatment is conducive to the primary care setting. For those out there that are already kind of taking part in this work, thanks for stepping into the foray. And for those that are interested in taking on this work, if there's anything that we can do at Neighbor Care to kind of help you in that effort, please don't hesitate to email me. And thanks so much for the time today to talk about this.
Thank you, Megan. Really appreciate that, and also really appreciate the opportunity to follow up with you if any want to do that. So thank you. But we're going to save all the questions until the end. Just a little reminder from the beginning, and it is now my pleasure to introduce Julie Richards. And Julie, I'm turning it over to you.
Great. Thank you. And it's been really fun to listen to my co-presenters. So thank you for your presentations. I'm assuming people can hear me because I haven't heard anybody say I can't hear you yet.
We can hear you. Thanks.
Okay, great. So I'm Julie Richards, and I'll be talking about the integration of care for suicidality in primary care today. Next slide, please. So I want to start by telling you a little bit more about me. I'm a health service researcher at KP Washington. I'm not a clinician, but I routinely work with providers who are really critical for informing the qualitative research and the statistical evaluations that I do. In the last 10 years, I've been focused on suicide prevention research and research designed to improve care for patients with depression, alcohol, and drug use disorders. And here's a citation of the work I'll be describing in more detail today. This was a collaboration between delivery system leaders and researchers at KP Washington. I also have some personal experiences that have impacted my research. This is a picture of my mom with my daughter almost 10 years ago. My mom died by suicide in 2010. And I feel like it's important to share this with you just so that you have a little bit of information about my perspective on this topic. Next slide, please. So I'm going to start with the 3 key points that I hope that you'll take away from this presentation. First, screening and follow-up for suicidality is feasible in primary care. Second, teamwork alleviates fear and takes the burden off individual providers. I'll cover these first 2 by describing our experience integrating care for mental health in the primary care delivery system at KP Washington. Third, resources and safety planning enhancements are available to help individuals at high risk of suicide who need them now. I'll show you some examples of these resources developed in collaboration with those who have lived experience with suicidal thoughts and prior attempts. I also want to mention here that this includes providers. So on day 1 of this summit, I heard Carrie Rose talk about her father, Robert Bree's death by suicide. So I just want to call out here that the resources I'll describe are meant to be helpful to everyone, including physicians. Next slide, please. So moving on here to a little background, what's the rationale for providing suicide care in primary care? Well, we know that most individuals receive healthcare services prior to death by suicide, about 50% in the prior month, 80% in the prior year. Most of the care these individuals are accessing is in primary care, suggesting that there's an important opportunity for suicide prevention in this setting. Next slide, please. Relatedly, as many of you are probably well aware, screening for depression in primary care is widely recommended, but recommendations are mixed for suicide risk. The Joint Commission recommends routine screening for suicidal thoughts, but the United States Preventive Services Task Force found insufficient evidence to recommend suicide risk screening in primary care. These recommendations are actually being updated now, so this very well might change soon. Nevertheless, depression screening instruments like the PHQ-9 often include questions about frequency of suicidal thoughts. So regardless of the national recommendations, there are a lot of patients that are being asked about suicidal thoughts in the context of depression screening and follow-up care. At KP Washington, we've been using the PHQ-9 in primary care for many years, and recently we asked patients about their experience answering. So on this slide, you'll see a reference to a paper we published last year and a diagram of some themes in that paper we described. I won't go into a lot of detail, but the big takeaway was all patients we talked to believed being asked questions about suicidal thoughts was appropriate. Though some who disclosed suicidal thoughts described experiencing stigma and sometimes distanced themselves from suicidality. So we learned a lot in that study, and we're applying that to research in progress now. Next slide, please. Next, I'll move on to mental health integration at KP Washington. This began in 2016 and finished rollout in July 2018. Some of you on the call today might be real familiar with this work because it involved a lot of KP staff, providers, and leaders who were instrumental in the success of this project. The integration started with annual screening for adult patients coming into primary care. Clinic receptionists or medical assistants gave a 7-item paper screen to complete prior to their visit, which includes the PHQ-2 for depression, the Audit C for alcohol use, and 2 questions about cannabis use and other illicit drug use or non-medical use of prescription medication. Data from the screen were typically entered into the electronic health record while patients were being groomed, and severity assessment tools were available to guide clinical decision-making, like for suicide risk. Clinical social workers were also trained to support primary care teams, which I'll talk more about in a couple minutes. A couple of new developments I'll mention here is screening now happens virtually because of COVID and the rapid transition of most of our in-person visits to virtual care. Also, children and adolescent patients were not included in the original mental health integration rollout, but one of my colleagues, Gwen Lapham, is supporting that workflow design now in collaboration with healthcare system providers and leaders. Next slide, please. 3 main implementation strategies were used during the 2-year rollout: enabling, supporting, and performance monitoring. Specifically, practice coaches met with local implementation teams routinely for 4 months to support new workflow implementation at each clinic. Electronic health record systems were designed to prompt clinical decision support tools, and performance monitoring metrics were developed to help leaders and local teams monitor implementation progress. Next slide, please. In our implementation model, the practice coaches were the main link to the clinical teams and shared their experiences and perspectives across the different teams involved in supporting the mental health integration, including the electronic health record programmers, the performance metric development team, and the leadership team, which included clinical operation leaders as well as researchers. Next slide, please. Here I'll transition to the workflows built specifically for depression and suicidality in KP Washington primary care clinics. I won't be covering the screening and assessment work we integrated for alcohol, cannabis, and other drug use disorders, but I did include some references to articles describing that work at the end of this presentation in case you're interested in learning more. So now whenever a patient has a primary care appointment, the electronic health record fires a prompt for mental health screening at least annually. The first 2 questions on this screen are about depression. Patients who answer more than half the days or nearly every day on either of those questions are asked to complete the full PHQ-9 on the back of the questionnaire, back of the screener. Next slide, please. Those with frequent suicidal ideation, defined in our system as a score of 2 or 3 on the 9th question of the PHQ-9, are asked to complete a self-administered version of the Columbia Suicide Severity Rating Scale. That questionnaire is shown here. When patients indicate intent or planning for suicide attempt in the prior month, that's a yes on question 3 or higher. Providers are prompted to make a same-day referral to a clinical social worker for same-day crisis response planning, which is also known as safety planning in other systems. Next slide, please. This is an example of the best practice advisory in our electronic health record that alerts providers when a same-day crisis response plan is needed. RNs in some clinics have also been trained to back up clinical social workers when needed. Next slide, please. The crisis response plan is set up as a customizable template in the KP Washington electronic health record. And this is an example of a real one filled out with identifiers redacted. So it includes the basic components of the safety plan designed by Barbara Stanley and Gregory Brown. First, warning signs of a suicidal crisis, which in this person's case included staying in bed. Second, coping strategies for this person included going to laser therapy, going for a walk, calling the daughter. Third, identification of a support person. For this person was the ex-husband. Fourth, limiting access to lethal means, which for this person included a firearm. And fifth, professional resources to reach out to for help, including the suicide crisis lines. In our template, we also document a follow-up plan, which for this person meant calling the behavioral health access line to schedule an appointment with a mental health specialty provider and reconnecting with the social worker in the meantime, if needed. Next slide, please. So here are some results of the screening and assessment in a month following mental health integration at all primary care clinics at KP Washington. I'll describe the numbers on this slide in combination with the barriers and facilitators we identified during implementation. We've also published these results in the paper I referenced at the beginning, and it's also included in the list at the end of this presentation. Beginning with one important implementation barrier identified early on was the concern clinic staff expressed about identifying patient needs without the time or resources required to address them. But we can see here at the end of implementation, 89% of patients were being screened for depression. That's of about 50,000 patients that were due that month for screening. Of those, 17% screened positive and 96% were assessed for symptom severity with the PHQ-9. A couple of important facilitators to note here are that medical assistants really took ownership of the screening process, and clinic staff were already really familiar with the PHQ-9. So going back to the numbers, we can see that the patients who were assessed with the PHQ-9, 6% indicated they had pretty frequent suicidal ideation. But an important barrier to note here is that during rollout, it took a lot of time to implement a prompt for the Columbia Suicide Severity Rating Scale in the electronic health record. Technically, that prompt wasn't that hard to develop, but a limitation of the electronic health record system required that we turn it on for all clinics at the same time instead of clinic by clinic as we were rolling out. So that took a lot of communication and coordination. After that happened, going back to the numbers, we can see that 86% of those with frequent suicidal ideation were assessed for suicide risk with the Columbia Suicide Severity Rating Scale, which resulted in a need for crisis response planning in about 24 per 10,000 screening visits. The critical factor to note here was the availability of clinical social workers trained and available to do crisis response planning with primary care patients in all of our clinics. And finally, the last facilitator I'll mention were the positive stories that local implementation teams shared with practice coaches about the potentially life-saving value of this work. Next slide, please. We shared a few of these stories across KP Washington with the permission of the storytellers. These included one told by a primary care physician about a patient who had come in for a simple wart removal when she was identified as being acutely suicidal and subsequently completed a crisis response plan and engaged in care for depression. Another story included a social worker told about a young man who presented with cold symptoms, but also reported suicidal intent and had easy access to a firearm. Next slide. Thank you. So moving on to the last part of this presentation, I'm going to share some resources and safety planning enhancements my collaborators have created to help providers help individuals at high risk of suicide at the time when help is needed. Access to outpatient mental health care, mental health specialty care is tough to come by sometimes. Again, this is something this audience is probably well aware of, but demand has surpassed the available supply of traditional mental health care. Therefore, we need effective alternatives. I'll show you a few examples of resources that we've created to help meet that need. So pictured here is nowmattersnow.org. This is a website my collaborator Ursula Whiteside and I have created. We created originally with a grant from the National Institute of Mental Health, and individuals who have experience with suicidal thoughts and attempts partnered with us on that project. Next slide. One of the resources available on this site is an enhanced safety plan. Ursula was inspired to create this plan by a qualitative project we did a few years back, interviewing individuals who had made an unplanned suicide attempt. She calls it an emotional fire safety plan, and it's broken down into categories of specific advice for different situations, like when you feel like you're on fire versus in a fire, working on fire prevention. Next slide, please. So one of the on-fire strategies she describes and teaches to clinicians is the cold water technique. So submerging your face in cold water is a technique based on the mammalian dive reflex. That's the physiological response that many mammals including humans, have to diving into cold water. Next slide. This technique can help us reset our brains when we might be experiencing intense emotional pain. And Ursula routinely teaches this to clinicians and her patients. Next slide. There are also a number of strategies described on Now Matters Now that were inspired by dialectical behavior therapy. And one of my personal favorites is opposite action. I think I'm going to skip over showing this, but in the interest of time, I'm just looking at the time now. But if you get a chance to check it out, Diana's video, I think it's really super helpful. Next slide, please. So another resources we just started using more at KP Washington was developed by Emmy Betts at the University of Colorado. It's called Lock to Live. Emmy and her team developed Lock to Live to help providers help patients at risk of suicide make decisions about securing lethal means, particularly firearms. So there are a lot of considerations when it comes to securing firearms, like storage options inside and outside the house, cost of storage solutions, and other requirements like background checks. These can be difficult to navigate, particularly during stressful times. This tool, like Now Matters Now, was developed in collaboration with individuals with lived experience of suicidal thoughts, as well as clinicians and firearm owners. This is the URL of the tool, which is publicly available, and it doesn't store any identifiable information. Next slide, please. At KP Washington, we've developed a way to integrate Lock to Live into our crisis response plan template. We've also developed a handout to help providers introduce the tool to patients based on guidance we received from patients who participated in qualitative interviews. And that handout will also be publicly available real soon, we hope. Next slide. So last, I just want to briefly mention work we began exploring on how to better integrate alcohol-related care in suicide care. I recently did some statistical analysis on the short-term risk of suicide attempt following a report of different patterns of alcohol use on the Audit C. The Audit C is a commonly used 3-item screener for unhealthy alcohol use. It's part of the 7-item health screen I mentioned at the beginning of this presentation we use at KP Washington with all adult patients at least annually. This graph is included in one of the papers referenced here that shows the predicted prevalence of suicide attempt within 90 days is substantially higher for patients reporting suicidal ideation across all levels of alcohol consumption. That's the orange line at the top of that graph, but especially those in the high level consumption group. That's the folks on the right-hand side of the figure. In these papers, we describe how findings underscore the potential value of addressing suicidal ideation and risky patterns of alcohol use together for purposes of suicide prevention. For example, providers may suggest to patients that high-level consumption and heavy episodic drinking appears to increase risk of suicide attempt, potentially by intensifying suicidal ideation, increasing impulsivity, and constricting coping and problem-solving skills. Providers might recommend treatment for alcohol use disorders as part of their care plan for these patients, including counseling and/or medications for alcohol use disorders. Next slide, please. And with that, I'm back to where I started. So our experience at KP Washington is that screening and follow-up care for suicidality is feasible in primary care. Teamwork alleviates the fear and takes the burden off individual providers. I've also told you about a few of the resources and safety planning enhancements we use now, and some that we're exploring to help individuals at high risk of suicide who need these resources now. The last slide, please. So thank you again for your time today. This is my daughter now, in contrast with the picture I showed you at the beginning of this presentation. We camped out this past weekend near Westport, and she convinced me to take a dip in the Pacific Ocean. So I practiced a little bit of my own cold water submersion techniques this past weekend, which were very effective. And I think with that, there's one more slide with some resources, but I think we're done with our presentations and probably ready for questions.
Thank you, Julie. And kudos to you for jumping in the ocean. It's very refreshing, right? So now I'd love to open it up to all of our panelists. So if you could, all three of you, just unmute yourselves. And if you would like to, feel free to go back onto the video. I always think that face-to-face interaction is so great. And we're all feeling a little badly that we are stuck in this Zoom world instead of being together in a room in a more dynamic setting. So I know some of the questions have been answered in the chat, but I'd love to revisit them because I think that discussion piece, and maybe all three of you can answer all of the questions too, if relevant, can just spend a little bit of time thinking and reacting to that. So the first one, and this was directed to Jenny's presentation on SBIRT, did the legalization of marijuana change the way that you communicate through SBIRT?
Yeah, so what I found, and I had to have a lot of conversations with my PCPs to make sure that we weren't giving, conflicting, discussions and really coming at things from that motivational interviewing perspective. So we agreed, across the group to really focus on treating it like alcohol. Alcohol is legal. But just because it's legal doesn't necessarily mean that it's, something that you could use as much as you want without any consequences. So we really focused on that perspective with marijuana and trying to think about how do we provide information to the patient. So that's where some of the depression screening stuff came in really helpful. Because if we saw that they were expressing lack of motivation or depressed mood, we could then have an honest conversation with them about how marijuana could impact those symptoms and make them worse. And that's where we got the most buy-in. But really just taking it from the perspective of just because it's legal doesn't mean that there's no potential negative consequences. So here's the research and just be informed. That seemed to be where we got the most buy-in. But we did find that from a engagement perspective, the ones that the marijuana was the only thing they screened positive for, if we were billing for SBIRT codes, that was am I going to get billed for this? Do I have to pay for this? That became a little bit more challenging to have them engage in the conversation. Again, where student support or during the grant really helped us to get through that financial barrier.
And another question about marijuana being legal as a barrier to reduction and elimination. And to me, this makes me wonder, the audit, essentially gives you permission to have a certain amount of alcoholic beverages per day based on your sex. And I'm wondering if there is research or studies that you've used with some kind of similar allowed amount of marijuana.
I have not looked into the marijuana research in a couple of years since we were really actively doing this when I was in clinic. But I do know that on the SBIRT website, and I forwarded that in the chat box, there are some handouts and things that does reference some different research. I know at one point we were looking into more specific screenings that we could utilize that really did tap into the marijuana use being different than abuse of prescription medications or other illicit substances. But I'm going to be honest, I haven't looked at it more in depth in the recent years.
And how would you describe the training of PCPs that they receive in delivering the brief intervention or motivational interviewing training?
Yeah, so there is an SBIRT certification course that's about 6 hours that a good bulk of the training is really around that motivational interviewing skill set and how to have that brief intervention with, a chunk of it being around the research around SBIRT and the protocols. So as part of the grant, we were able to bring a trainer into the clinic to train all of the providers at one time. And then each year there was one time that we could kind of do a conference and send people to get trained. But from a billing perspective, we did need everybody that might be billing for that brief intervention to be certified. So we did have to have everybody go through that 6 hour training, which again, really helped enhance and ensure appropriate intervention, but also became a really big time suck, and trying to justify people being out of clinic for that long and things could be a real challenge.
Yeah, well, that makes sense. Another question on, are there research articles that show the health impact of high and low risk drinking, maybe that you use as handouts, and do patients ever really want that type of evidence?
Yeah, so the Washington SBIRT grant and all the work that was done, they did create some handouts that we could give, and it really was more about facilitating the conversation. Obviously, there are always going to be some of those patients, depending on the clinic population, that do want more of the research, and so we would absolutely help to connect them. And at one point, I did have a list of some research articles, but in general, that one-page kind of just summary of the different impacts tended to be sufficient for 90% of the patients.
Okay. And then a final question related to SBIRT specifically. Why the question about whether or not the person is in recovery or treatment is not at the end of the universal screener or built into the SMART set as part of motivational interviewing, and a concern that might miss patients at risk?
Yeah, so we were really looking at this as a screening tool. So if somebody is acknowledging that they are currently in treatment or in remission, we don't need to screen them for current use. So instead, that question kind of saved them from answering a bunch of questions that they could get frustrated, like, well, yes, in the last 12 months, I was drinking this amount, but now I'm not. And so we kept them from moving on to the full audit or the DAST, but that did not preclude us from the PCP seeing that response and being able to initiate a conversation. So especially if the PCP was not already aware of their use or their treatment, that allowed for a facilitated conversation. So it was really more about helping the patient not fill out a ton of questionnaires that maybe they didn't feel were as relevant to their current state, but did allow for conversation with their PCP and or the behavioral health provider being included to help facilitate and be a bridge for their care team.
Okay, thank you. So a question for Megan. How do you define misuse of prescription opioids for chronic pain?
That's a great question. So misuse, simply defined, is just taking an opioid medication other than how it was prescribed. So for a patient that's, for example, getting an opioid for a chronic pain condition, which hopefully we're starting to move away from in general, but for patients that are still kind of in that boat, let's say they were prescribed oxycodone 10 milligrams 3 times a day, and then kind of interviewing them and talking with them, you find out that on some days they may be taking slightly more than that. That would be misuse. That same person, when you go through kind of the DSM-5 categories for opioid use disorder, may not meet the criteria for that. And so for that particular patient, opioid misuse would probably be the most appropriate diagnostic factor for that individual. But that isn't to say that opioid misuse and opioid use disorder have to be mutually exclusive. Oftentimes we'll find opioid misuse as kind of a part of a larger opioid use disorder in an individual.
Okay, thank you. And then a question for everyone. I'm wanting to think about when we'll take folks through our action plan, and when you were all starting these initiatives early on, how could you just think about how would you advise somebody kind of make the case to their leadership in the organization, and then how they would sort of make the case to their colleagues in an organization? And Julie, we can start with you.
That's a tough question, and a super important question. I feel like the leaders in our system were already bought, especially the leaders in our mental health department were already pretty bought in to this whole idea. So really, in our organization, it was making the case to invest resources in primary care. And I think that conversation evolved over time. So for us, it was really like, figure out a place where you can start and have some success, maybe not try to do everything at once, but try to, that's why I think we planned it the way we did. We rolled out over the course of 2 years. I think if we tried to do everything at once, it would have been a lot harder. And then we sort of like built iteratively as we went along. So by the time we got to the end of the mental health integration effort in our system, there was a lot of people that were a lot more excited about it than they were when we first started out. So I'll stop there.
Megan, what would you say to that?
I would echo a lot of the things that Julie mentioned. I think having good data to back up kind of the need that you're seeing and the benefit of implementing a new project are really helpful, especially for so many folks in healthcare that are really driven by data. And then I think for us, something that's been really beneficial is being able to offer support to staff that are engaged in this care. It's a lot harder to start something new if you feel like you're kind of all out on your own. But if you feel like there are resources that you can go to help you through, that's really beneficial. I think for us at NeighborCare as well, and I'm sure at almost all the organizations that work in healthcare, our focus on trying to meet the needs of patients is really central to our mission. And so any projects that we can take on that kind of help to drive that work forward usually find good support for us at NeighborCare.
Yeah. And Jenny, anything to add from your experience?
Yeah, I mean, I again echo what Julie and Megan have said, that really taking it from and arguing things from a population health perspective, showing the research on the downstream impact of reduced healthcare utilization, reduced cost of care, as well as just emphasizing this is the right thing to do. That yes, it does cost when it comes to resources and making sure that you have the appropriate mental health, behavioral health trained professionals to support the positive responses. That was absolutely one of the things that I ran into, is that anytime we tried to do some screenings and things in clinics where they didn't have immediate access to a behavioral health provider, anxiety around, well, if I screen for it, I've got to do something about it. And who's going to help me? How's it not going to blow up my schedule for the day? So having those appropriate resources available and having a lot of success stories, but use patient stories, use the actual patient, from Megan's presentation, those are so powerful. And that's really what I find with leadership is humanize it. That the statistics are one piece and are powerful, but humanize it and talk about the value and really how this is how we provide holistic, whole person care.
Yeah, thank you. Those stories really are powerful. So a question for Julie. There is some unpublished data relating to benzodiazepine use and suicide risk. Have you or others at KP looked into that at all or addressed that, since benzo use is so common for anxiety disorders?
Yeah, that's a really good point. I think benzos in combination with other things like opioids can be particularly dangerous, and alcohol use as well. I know there's been some research on it, but I'm not super well acquainted with the papers. But if I find them, I'll pop them into the chat box. Thank you for that question.
Okay. Yeah. So another question, we see suicide attempts increase with negative social determinants of health. What projections of suicidality are seen, due to our current pandemic and unemployment, housing insecurity, et cetera?
Another super, super timely question. I don't think we know yet in terms of, how COVID is going to impact suicide rates, but there are a lot of people that are making a lot of guesses about what's going to happen. I think we'll all learn a lot real soon. There's so many different things happening at the same time. I think it's also going to be really difficult to kind of pick apart the different things that are affecting everything at the same time, increases in substance use, but also maybe sort of like a coming together. around different social issues that are happening right now. So I don't know. It's fascinating though. I mean, so we'll see.
It's definitely a hard time. And I'm curious if there are any kind of internal preparations going on or discussions. And Jenny and Megan, I'd love to put that question to you as well. Reactions to COVID, economic downturn, anything else really it's on your leadership's mind.
I know at NeighborCare, we've talked about the potential of actually having an increased number of patients that would be eligible for Medicaid because of the unemployment issue, and that potentially NeighborCare may see an influx of new patients regarding that. Also know anecdotally, a lot of the patients that I've been talking to via phone for Suboxone care that in the past had not been interested in behavioral health counseling are now. That a lot are taking advantage of the ability to have a phone visit with one of our counselors. And often ascribe that to increased isolation and just stress of everything that's going on. So I guess on a positive note, patients being able to sort of self-recognize that they need that care has been a good thing.
Yeah, I think we are aware of the potential third wave that following all of the changes and the isolation and the economic downturn, that all of these things are a perfect storm for increased behavioral health needs. So at Swedish, we have shifted my primary care team to fully virtual for the interim, and we use the PCBH model. So we typically work as a care team member of a specific clinic. But in response to the COVID crisis, we expanded our services across our entire system just to make sure that patients could get that access. And we have really just made services as accessible as we possibly can. And just knowing that we're all going to be stretched for a period of time. But we have, to the question that just popped up, there's been a huge effort around provider wellness, caregiver wellness. That is absolutely one of our top priorities from a leadership perspective, that we have to take care of ourselves to be able to care for the influx of mental health and behavioral needs that are going to be coming through. So we are doing a number of proactive outreach efforts, as well as just creating a gratitude garden online and a number of additional options for how patients and caregivers can access support, and just making sure people know that we're here and that we're not going away, and that the mental health needs are just as important as the physical health needs.
Thanks, Jenny. And thanks for responding to that most recent question coming up in the chat. And Megan, I'd love to hear your insight on that as well. Can you say something about healthcare and behavioral health providers' mental health? How might clinic closures, et cetera, impact a provider's physical and mental health?
I'm sorry, I missed the very tail end of that question.
Oh, can you say something about healthcare and behavioral health providers' mental health? How might clinic closures impact a provider's mental and physical health?
Yeah, so I think we can all feel that on an individual level, and of course, kind of gradations for other factors for people's lives. I think similar to some of the things that Jenny mentioned, our organization has tried to be able to reach out to providers and other staff to talk about things that we're doing to help kind of mitigate the stress during this time. I know I've had offers from my own personal leadership team with things going on surrounding kind of racial injustice at the moment. If staff need to take a day off, that's acceptable kind of during this time, and just kind of a lot of checking in with each other to see how things are going. So I would say I don't know if we have anything very, very formalized at this point, and maybe that will be something that comes out of this whole experience, is how can we kind of better support each other through this process. But I think there's been a lot of organic things that have been occurring just to make sure on a human-to-human level that people are doing okay. Yeah.
Thank you. And Julie, thoughts to add?
In terms of clinicians, I think, you know, just kind of going back to my original point, I mean, and why I sort of like make the point during, you know, a lot of the talks that I give about this, you know, I open with a little bit of my own lived experience. And I think it's just important for us maybe not to separate ourselves, you know, clinicians, researchers from, you know, the patients that we serve. I mean, we all go through the same struggles. I mean, and that's like a lot of the tools that we've developed, I use myself in my own life, you know, like mindfulness, opposite action, paced breathing, a lot of the skills that we try to teach others, I think are so important for ourselves as well. I mean, and it helps us be better teachers too, to our patients. So that's, I guess, the only thing that I would add. Thank you.
And Megan, you brought up the point of racial injustice, police brutality, and kind of the health equity that's sort of woven in that as well. I'd love for you to just, and the others too, to touch on that and maybe how you see the intersection of health equity and behavioral health.
So I think we've known for a long time, and maybe it's just gotten more salient in the last several weeks, that racial inequity is a public health crisis, and that we see it both in physical aspects of health as well as in behavioral health aspects. I think for me personally, part of that understanding has been to realize being a clinician and trying to incorporate that into the way that I interact with patients isn't enough. That I need to take more of a public stance on the crisis and kind of bring it to the forefront of people's awareness in my own personal circle, and also more broadly, that we as a healthcare community are seeing the impacts of so many years of structural violence and what that does to our patients. I think on an individual level, checking in with patients across the board with how they're doing, and recognizing that in real time that this is impacting people's health is also important. To not kind of gloss over underlying factors that are affecting people's mental health and physical health in this moment. And again, I suspect that for my anecdotal experience of seeing more patients being interested in accessing behavioral health counseling, that this is probably an element of that, and I'm excited to see people that are reaching towards that service.
Jenny, Julie, anything to add?
I would just add that, yeah, I mean, trying to elevate the voices of the people of color in our organizations as well. I mean, and again, you know, bringing up the same thing I just said, but you know, I think lived experience is so important for teaching us all how to like respond better and understand the limitations of our own experiences, and you know what we might be missing when we talk to our patients. So just really like the importance of listening and compassion comes up a lot in my conversations with patients.
Yeah, I think this conversation could go on for quite a while. So I'm just going to highlight that I think creating the space and making it okay to have those conversations and to derail a meeting if we need to. I shifted the entire topic of one of my recent meetings so that as clinicians, everybody could just have space to acknowledge how they've been impacted so that they can be there to support the patients in the work. But I think systematically there's just so many changes that we're going to need to be making over the coming days, months, years, to start to dismantle these systems that have been in place and the disequity that we see across the system. So it's going to be a work in progress, and I think just being willing to acknowledge that there's work to be done can be extremely powerful.
Yeah, thank you. Okay, so one final question. Thoughts on using virtual assistants to help with identifying and guiding patients to care? And I will just throw that out to all three of you.
So I can speak to that a little bit. We definitely had at our larger Providence system, we had some creation of bots that when you went to the website, you could answer some questions and it would recommend different avenues of care, as well as with our caregiver wellness, we created a stress meter, and based on how you answer the stress meter, it would populate with some different levels of potential support and help to connect. And I think that that's a great way to allow people to explore and think about what level of care they might be willing to access. But as with anything virtual, I always caution against removing the human element too far, because there is something so powerful to be said for just sitting in a space with somebody, even if it's through a computer, that sharing a space and creating that opportunity for discussion. A computer can't replace that. So really thinking about how to use the technology to help people to access the appropriate level of care, but that doesn't become a replacement for the care.
Yeah, I just want to echo that same point. Jenny's point, I think, is really important. Especially with, I think, mental health, when people are experiencing, intense emotions and pain, I think sometimes it's really hard to like motivate yourself to do anything, and like interacting with a bot might be really difficult. So I think it's just something that, for us to be mindful of. I think it's great though that these tools are available, but also I think we can't necessarily undervalue like the support, that like human contact, whether that's through a computer screen, if that's what we have right now. I think that's, still really important.
Yeah. And then one final question. I realize I'm going against what I said earlier. There have been several webinars this person's come across that are focused on supporting providers in mental health during this COVID pandemic. Have you seen providers finding those helpful? And could you just talk about that before we go to break?
I think probably there's been a wide people have had a wide experience with how helpful they find different things, which is why probably it's so important to have a variety of tools available for people. Speaking personally, I think I also like change my reaction to some of those tools like every day, right? Like sometimes it makes me angry to like see like, oh God, another tool, another like thing I can go like check out, but sometimes I'm like, oh, that's really nice. So I don't know. I think it's just important to have it out there, have things available for people to use. But anyway, that's just my personal experience.
Yeah, I'm going to just echo that. I think that it's very much an individual experience, but definitely created a list of all the different resources. And from my caregiver's perspective, I think they have appreciated getting into those more so that they can figure out how to better help their patients. So again, taking it more from a patient perspective than for their own perspective. I think that's how, the groups that I've worked with, that's how they have really approached it. But it's nice to have, and again, giving people options of how they want to support themselves and support their patients.
Okay. Thank you. Well, thank you, Jenny. Thank you, Megan. Thank you, Julie. I really appreciate your time. And I know we went a little bit over our allotted time. So we will take a short break until 45 minutes past, until 10:45, and then reconvene. So thank you all. Okay, so I will bring us all back together. And in this next 15-minute segment, Amy and I are going to lead everybody through a very short, and we acknowledge that, activity to think about action steps that you all can individually do, and that as a community we can do together around all of our priority areas. So I want to just start by saying that in an ideal world, we would, of course, not be living through this traumatic pandemic. In this ideal world, we would all be sitting together at round tables together in the same room, able to talk to one another and to really see one another's nonverbal reactions. That's so valuable in knowing how what you said resonates with another person. And because I miss people and have been spending a lot of time in my own basement, as you see here, I've been listening to a lot of podcasts. And one of my favorites right now is Code Switch, and I encourage everybody to subscribe to that. In a recent episode, Why Now White People, the hosts have a series of conversations about why people who do not themselves identify as Black appear to have a new or renewed interest in racial equity. And one of the reflections from a white listener that struck me was, during COVID, I literally cannot turn to the things that used to distract me. I have felt a physical vulnerability that has shifted my priorities. COVID has made me realize that staying alive in America is a struggle for many and is a thing that many white people take for granted. We've known for a long time that whether or not you are anxious, whether you have 3 glasses of wine a night, whether or not you smoke, these all contribute to your health. And I would add that many of us have known for a long time that whether or not you experience racism also contributes to your health. And it seems that our country is really, some of it, learning for this for the first time this year. Our healthcare system, of course, was not designed originally for people with mental illness, with substance use disorders, and we need to change that. And I think the work we're doing around our table today really is helping to change that. On a recent talk, Seattle-based author Ijeoma Oluo recently said, while a self-admitted fan of therapy herself, that therapy is really not built for Black people. It has to prove to be a place that can be trusted. It is not good to go into a mental health space and be harmed. We have to change the industry. And we do need to change our industry. We need to call out implicit biases to start, but of course, that is not enough. So Erik Erikson said, life really doesn't make sense without interdependence. We need each other, and the sooner we learn that, the better for us all. We really aspire to grow our pilot group into a statewide learning community, a safe table for everyone in our healthcare ecosystem to be self-critical, to grow, and to change together. We have to incorporate anti-racist work into this integration. We have to see this as another area through which true whole person care can be built. We also have this huge healthcare system where we all work that really has so much potential, but I would argue needs a little nudge. And since we're not in person, we'll ask for your patience and grace as we move through a virtual experiment of thinking about the changes that you want to build within your organization. And a lot of our work is really focused on the delivery system. And I know that we have those from hospitals, health insurance plans, purchasers, state government, and others present here as well. And we're going to ask for you to be creative as we move through this activity, as supporting whole person care is really a job for everybody. So we're once again going to be using Poll Everywhere, and I'll direct you to the screen up here. You can also text your responses as well. So we want to mimic as best we can that type of dynamic conversations we have in small groups. And so that's why we're asking you to reflect and to write your response up on the screen to inspire others and to really give us a sense of where this group wants to move. So I will pause there and we will spend a couple of minutes filling this out.
Thank you, everybody, for participating. I'm going to leave this open before I lock it and just kind of talk through what our next steps are after I do lock this poll. In addition to participating in the poll here up on the screen, if you haven't yet, please open up the worksheet that was attached to your meeting invitation. If you're unable to access that, Alex will put a link in the chat box where you can also download a copy of that worksheet. And so during this exercise, again, we ran a little bit over in our panel discussion, so it's going to go quicker than we had anticipated. But we're asking you to get a little introspective. I think we've all kind of improved our introspective skills over the last few months of self-isolation. So as you wrap up participating in the poll, take a few minutes to put some intentional thought into how you achieve the ideal state of whatever priority area you've chosen that you're currently voting on. So we're going to ask you to think about your ideal state and then fill out your ideal state, your current state. I'm sorry, I'm out of order. Current state, then ideal state, and then also identify 3 barriers that keep you from achieving that ideal state. So maybe currently you've identified social determinants of health as the priority area, and you've identified wanting to incorporate a screening tool like Michelle talked about this morning. But maybe you haven't worked that yet into a workflow, or only a few provider teams are using it. It's not standardized across the clinic, or your EHR doesn't have a good way of tracking the results you're getting in or doing anything with the information you're collecting. So think about what your ideal state related to that would be. And here I'm asking you to dream big, like we talked about at the beginning. Maybe give your clinic a care manager who can do all that follow-up outreach, or give yourself a screening tool that integrates with a patient chart in your EHR. Don't limit yourself when you're thinking about your ideal state here. And then for our non-clinical friends who are participating, think about this in terms of the people and the providers and the clinics that you serve and work with. Like if you're an MCO, maybe think about something around improving the data you provide related to racial disparities or data around mental health utilization. So go ahead and wrap up participating in this poll here, and then spend the next few minutes. I'm going to time us so we don't go too over, but spend a few minutes filling out those first 3 questions on your worksheet, on your action plan worksheet. So I'm going to give people about another minute to fill out those first 3 questions on your worksheet. We're going to kind of break up what would have been this half an hour into incorporating some of what we would have done in the last 15 minutes, just so that we can maintain the schedule for our MCO panel, because I think some of them have time constraints. So we will still start our MCO panel at 11, but for now, go ahead and continue working on those first 3 questions in your worksheet. And then I am going to lock this current poll and direct you to thinking about what are some of the barriers that you identified that keep you or your organization from achieving your ideal state. And so this is back to our word cloud format that we've gotten used to. So feel free to share some of the ideas that you identified as you're completing this worksheet.
So this is the part that I find so frustrating about this virtual webinar format. I'd love to discuss what we're seeing. And I'd love to have those types of conversations where we can talk about solutions that folks have come up with and connect people with those who have come up with those solutions. So I'm seeing access as the biggest barrier here. And I think that's so important and really reaffirming that we all have this shared experience of a difficulty and really creating change and really can create a learning community where we can learn from one another. So I'm just looking at the time. We have about 2 minutes left for this exercise before we move into our MCO panel. And so in that time, I would ask you to look at question 4 on the worksheet, the resources you need to remove barriers, and ask you to fill that out while we transition to our MCO panel.
And then also for our Molina representatives on the MCO panel, we're not seeing your names to promote you to panelists. So if you're calling in via a phone number, if you could identify yourselves in the chat to us panelists so we can promote you so that you can speak on the panel, that would be helpful. Thank you. I'm just going to give a minute to key up things and get everybody promoted accordingly that Alex is working hard on. Thank you, Alex. So again, if Whitney or Vicky is using a call-in line, our Molina representatives, if you could just identify yourself in the chat, that would be helpful. Okay, I'm just gonna pull up our next bit. So as I mentioned earlier, this next section is going to be on billing for behavioral health in a primary care setting. I'm just going to share my screen so you all can see what I am referencing. Give me one moment. Okay, so a big welcome to representatives from the Healthcare Authority and our Medicaid managed care organizations who have agreed to join me today. There have been some questions just as I've been doing this work around how to bill correctly and really bill to the best benefit financially for the clinic for behavioral health services in a primary care setting. And so when we originally were going to do this in a live room, we would all be sitting up on a stage and or around a table talking to you. So it might be a little bit trickier here in this virtual format. So I appreciate your patience as we do this. So I did collect some questions from the pilot group that I'm working with before coming to the summit today that the representatives have gone over together and will be answering. And so what we're going to do is I'm just going to kind of read them out, and then various members of the Medicaid managed care organizations and the Healthcare Authority are going to answer. So I'm going to start with our first question. Can you talk about the auto assignment process to behavioral health insurance plans? Sometimes patients are assigned to a different MCO than the patient's medical plan. What are current efforts to improve this process? I'm hoping everybody who needs to be is currently unmuted. If not, Alex, do you think you could work on that? Is anyone on the panel able to answer this question? Let's see. If one of my, I have a few things up on the screen, so I'm not able to get back to the panelist box. So if one of my BRIE collaborative cohorts could help with muting and unmuting people as necessary, that would help. It looks like I got a notification that maybe Howard raised a hand. This isn't going well. Give us a second. I think that also just a reminder to the panelists that you do need to unmute yourself on your own side. So I think I heard somebody say.
This is Donna Arceri with Community Health Fund of Washington. Can you hear me?
Yes, thank you, Donna.
Hi. I was hoping, I just wanted to ask a question to see if Gail Krieger was on the line or if she was able to be unmuted or put to a panelist level. I think we were hoping that she was going to start us out with walking through the healthcare authorities processes as it relates to these questions. We're all trying to stay very aligned with the healthcare authority processes, so
Sure.
we were kind of hoping she would take the lead.
Gail, are you with us? You may need to unmute yourself on your end, Gail.
Hi, this is Donnell with the Mayor Group. Gail did note that she has unmuted herself, but folks still can't hear her.
Interesting. I'm not sure how to troubleshoot that because it does look like she's unmuted on our end. Alex, if you have any suggestions. In the meantime, would anyone else from the panel feel comfortable tackling this one while we work on Gail's audio?
I think she's pretty key as it's really driven by the healthcare authorities auto assignment process.
Okay, maybe we'll move on to one of the other questions then. Would that work for some of the panelists to feel if we went to a different question while we waited for Gail to get her audio established?
Hi, Amy. This is Josh Morse at the Healthcare Authority. Can you hear me?
Yes. Hi, Josh. How are you?
I'm doing well. Thank you. Yeah, that's probably a good idea. I think Gail is probably the best positioned person to address the question about auto assignment right now.
Sure. So then our next question is, what's the best way to capture more billing for risk stratification process, such as appointments that are not scheduled, behavioral health provider consulting with MD during PCP visit, brief contact of 15 to 20 minutes, etc. Would anyone like to take this one? Anyone? Anyone who's been able to unmute themselves?
Hi, this is Josh, and I'm not sure what's meant by risk stratification process. Is that the billing for screening?
I believe so. This was how it was submitted to me, and I don't have the any follow-up communication around it. But I guess we could just dive into the appointments that are not scheduled, behavioral health provider. Like, how do you maybe tackle some of the other components within that question?
So we did a few years ago in response to Senate Bill 5779 address the health and behavior codes, which can be used for services like that by behavioral health providers in the context of a meeting or a visit where the client has come in for a physical health treatment, but then there's identified behavioral health follow-up necessary on the same day.
Okay. Would any of our MCO representatives like to add anything? And if you're having issues with audio, feel free to add into the chat as well, and Alex can try to work on that for you. I apologize, everyone, that this is having some technical issues.
And additionally, Sarah Barker just commented about the collaborative care codes, and I wouldn't want to forget those either. That's appropriate
Absolutely.
for clinics that are set up that way.
That's absolutely right. And I was intending to, when we send out resources at the end of today, later this week with the recording and everything, I was going to add some sort of helpful links and resources, and I was going to use the links to collaborative care on the UW-Ames website. So thank you for calling that out as well. So we have another question around behavioral health providers working in a primary care setting and their ability. So I'll let you read this and see if anyone on the panel would like to address this question.
And Gail, we just request if you wouldn't mind recalling in. Maybe there's an issue with the Zoom internet link, and it might work better if you use the phone option.
So for Community Health Plan of Washington, as it relates to this question, the process to utilize these area codes would be to work with our provider relations and contracting department to understand the services that you're providing, the scope of the licensures of who's delivering the services, and then we would have a conversation of whether or not that's a coverable service for that licensure or not. But it's just literally a conversation.
Okay. Any other MCO representatives have anything to add?
Sorry, go ahead.
A similar process for coordinated care.
Similar process for coordinated care. Okay, thank you.
And this is done out with Amera Group, and it would be similar. We would want to also probably review how you're contracted with us, as well as the provider type, just to ensure the services would be appropriate and payable.
Okay, great. Any other additional comments around these theory code questions? Before I move on. And then as well, Gail, when you are with us, feel free to announce yourself, and Alex will keep an eye on when you're re-logged in to promote you to panelist status. We have another question around multidiscipline consultation time for Medicaid and or Medicare. Can we bill for time spent discussing patient care? Would anyone like to tackle that one?
Well, I know we mentioned the collaborative care. I assume this could be covered there. I'm not sure of a specific code just for discussing patient care, discipline consultation, but do any of the other NCOs have any thoughts on the type of service besides collaborative care? Might be another good one for Gail.
Okay.
This is Josh from the Healthcare Authority. I'm not aware of a consultation code that is currently payable. We do have referrals, or what am I trying to say? We're working on addressing e-consults for formal consultations, but if this is for time discussing like a phone call, I don't think we currently have those as a payable service.
Can anybody hear me?
Yes, we can.
Oh, thank goodness. This is Whitney from Molina. I've been trying for a long time. I don't know if I was just moved to a panelist, so I did get a mute and unmute button now that I didn't have before. So I had tried to hold the space bar if everybody wants to know what the process I went, but anyways, I apologize.
No, we apologize. Thank you.
On the previous question, we are similar to the other MCOs, just so everybody understands. For Molina, we're the same. We would want to make sure that the license for the that a provider has and what they're contracted for supports what they're wanting to submit for. And then for this question in particular, this is more the store and forward part of the component that isn't quite yet acknowledged, to our knowledge, by HCA for reimbursement. So we're not, except under the collaborative. So I believe, Donna, you mentioned that. And that's true. But I think if somebody doesn't qualify or isn't set up and meet the requirements to bill for the collaborative codes, there really isn't, to my knowledge, there's a way to get reimbursed for this yet.
Okay, thank you.
And this is one of those that would be helpful because I think Gail would be speaking to a lot of these. So it's really, I think she's a key speaker in a lot of this because we are aligned a lot, and we'd had, prep meetings for this. So I know that once she can be able to speak, that she will, it will help align a lot of this a lot better for you.
Yes. So Gail, I just made you a co-host. I'm hoping that should allow you to speak. Do you want to try? Gail? Because I'm not showing that you're muted on our end, so I'm not sure how else to bring you in. I think I'm not sure what else we can do on our end. So I apologize.
Maybe holding the space bar down on the first application, and then when you get the mute button, she might have gotten that, and then you have to unmute that too.
Gail, did you hear that? Hold down. Can you repeat that direction?
Hold down the space bar to unmute on the one part where where you have the hand raised. That's all I had initially. Okay. And then when I got the mute button, I actually unmuted that too. So I was unmuted in both places.
We'll give Gail a second to try that.
To follow up or add on to what Whitney was saying, and this is Christy from United, I think what might be helpful for providers to know is that all of the managed care organizations really follow the billing guides and coding that the HCA is using. So a lot of resources for what's billable and what's covered can be found both on the state's website, and then if there are specific questions for an MCO on whether they differ from what the state covers, then providers are always welcome to reach out to the MCOs and discuss any specifics on what might differ.
Hi, this is Josh, and I will completely agree with that. And I think, again, it was Sarah who pointed out that addressing the consultation time, that there is currently a covered code for interprofessional telephone, internet electronic record assessment and management. It's we have a large number of billing guides specific to COVID. This is a CPT code 99451. And our Q&A on this says, what about e-consults? And it says, during this crisis, we temporarily allow the following code to be utilized when consultation between other specialties occurs. So this code can be used in this context. I think it addresses the question during the public health emergency.
Thank you for that, Josh. I'm going to ask Gail to try talking one more time. We unmuted you again on our end to see if that might help. I'm hearing a resounding silence, so I'm assuming it did not help. I apologize, everyone. It does sound like Gail would be the wealth of the fill in the blanks of knowledge that we were looking for some of these answers. Do any MCO representatives or Josh, do you have anything to add about any of the questions or topics we've talked about before I just talk about our additional resources that will be sent out? And then in addition, I welcome the audience to submit any questions that they may have that you would like me to read out for the panel. And then I see a question from Sarah Barker from the UW-ABE Center. are you using 99446-99449 at all under Medicaid for interprofessional consultation? These are codes I am just starting to get more familiar with under Medicare. Any comments from the panel on that, or the audience for that matter? Okay.
So thank you for that question, Sarah. We do have some guidance on 99446, and this is a covered code in Medicaid. It's not just covered during the emergency. We have this code, that specific code covered.
And then I would also really like to direct everybody to take a look at the FAQs on the HCA website. There's a wealth of information there, and it's, from what I understand, consistently being updated as things change, as things are consistently changing. Josh, do you have any other healthcare authority resources that you would want to direct people to?
We have a variety of resources that I'm referencing regularly, including the physician's billing guide, where much of the questions that have come up so far are located. And then we have our COVID-19 specific documents. And again, there's a lot of them, and there's a lot of very detailed information about the specific billing requirements for telehealth and some of these other services that are only allowed during the public health emergency, for now anyway. And then our mental health billing guide also has important references.
Great, thank you. And then I wanted to call out the University of Washington AIM Center office hours that are extremely helpful, that occur on the third Thursday of every month at 10 o'clock. And the dates for the rest of the 2020 office hours are on the screen. And again, these links will be sent out to everyone with the recording of today's event and the slides from earlier panelists. I'm not sure, it doesn't seem like we've been able to get Gail's audio to work. I will ask Gail to try talking one more time. I'm not sure if we can proceed anymore, unless there are any additional questions from the audience or any final thoughts from the MCO panelists and or Josh.
I did see one question, and I think something that's been on all of our minds really is the transformative effect of this pandemic on telehealth. And just pausing there and thinking about that and thinking about things that we might want to continue post-pandemic. And so Jenny O'Donnell asks, is there any sense of how telehealth will be paid post-COVID?
Hi, this is Josh, the Healthcare Authority, and I'll comment on this. I think it's yet unclear, but my personal hope is that it will be covered broadly. I think we expect the utilization for telehealth once this pandemic ends to level off somewhere below where its peak will be, but certainly it'll be much higher than it was prior to the pandemic. We are actively working on ways to measure the utilization of the telehealth technologies now and what the utilization impacts are. And we'll be using that information and certainly lots of other data to inform where we go with policies when the pandemic concludes. But I think that's a ways out. But that's what we're beginning to work on, to figure out what we do policy-wise when we start to move out of this pandemic.
And then Gail did comment that they will be developing future telehealth policies, and they want to continue what they've developed within the framework of existing HIPAA rules. So we'll keep you all informed as we hear more from the Healthcare Authority around that. And then Stephanie, who's with CHPW, did comment that regarding telehealth coverage, I believe this is being discussed by state legislature next week and by CMS currently. So again, we'll keep you updated as we learn more moving forward. I think this panel discussion, it will be cut short. Again, I apologize, everyone. It was a little painful. Gail, if you'd like to type in any comments before we wrap up this section and return to action planning.
And I'd also like to just pause and reflect a little bit on the fact that there are so many moving pieces in our healthcare system, and our delivery systems, we're asking really big changes from them, and our health plans, these are big changes. And so it really is a whole person, whole community type of transformation here by integrating behavioral health into primary care. But of course, I think we all are really bought into that vision. And so I'd ask for everyone to think about that and to use this as an opportunity to be really open and supportive of one another as we all move forward into this changed future. And then if there is anything the MCO panelists or those from the Healthcare Authority want our delivery system partners to know or to think about or to prioritize, it's another opportunity for that as well. And then vice versa, we ask anybody in the audience to type in what you want our MCO or our Healthcare Authority partners to prioritize or to know in the chat.
Not seeing anything coming in yet. So I think that we will have to move on. I think that unfortunately we are not able to get Gail's audio to be able to participate in the panel.
I think just from the MCO's perspective, we just encourage that the conversations continue, specifically where we can help and in understanding how to bill, and all those things are very good conversations. Staying close with the Healthcare Authority and utilizing all of their tools as well that they have online is a wealth of information. It's certainly coming directly to the MCOs. We try to be similar, if not the same, in how we operate, and just keep the conversation going. Sorry, we couldn't have done a little bit more.
No, I think that this is part of the limitations of living in a computer world currently.
It is. I think we all have to give one another grace, as we said earlier, as we navigate this frustrating virtual space. I mean, I found in my meetings that there are a lot of pauses as people figure out how to talk and who should talk, and I just kind of have to step back and think that that is the new normal.
Gail, no need to apologize. We also apologize. But like Jenny said, we're all giving each other grace. And like we've all said, let's definitely continue this conversation. We've all are well aware of how many pieces are currently moving and moving very fast. And so we'll continue this conversation in another format for sure. And continuing to share information between all the relevant parties.
Okay. Any final comments from folks? Right. So we can move into our final portion. And this is really another opportunity for us to think about our individual and our organizational action plans, the steps that we want to push forward. So I really do want to just start off by saying I thank you deeply for your patience and for your presence today. I've observed that our healthcare system really is good at solving discrete problems, your heart, your lungs, but people, of course, are not discrete problems. So we really need a shift in expectations of what our healthcare system is, and a shift in what our health system delivers and how we pay for that. So we'll pause there and ask you to take a look at our word cloud again, this space where we talked about our barriers, and then ask for folks to write into the chat their reactions to what they see. Do they see similarities with the barriers that they are seeing within their own organizations? So we'll pause for a bit while people enter into the chat. So I'm seeing financial barriers as the elephant in the room. Thanks, Dale. We are in survival mode and behavioral health is seen as a burden rather than essential from Anne. Inertia is a good word. It becomes overwhelming at times, and this creates inertia. It's hard to keep the flame. All true. And I think it's so important to call out those elephants in the room. If we want to create any kind of change and especially sustain that change, we need to address those problems, those barriers. And the first step is really calling them out. So thank you, Dale. So I'm seeing resources get bigger, access still a huge one there. So before we move on to our resources question, Amy, I would just ask you, if you were having a face-to-face conversation with a clinic in an ideal world where we can do that, and access keeps coming to the top, what would be your next step? How would you advise them?
Yeah. Most likely it would be access, I'm assuming related to, primary care wanting to refer. If they don't have in-house behavioral health, they want to refer someone out for behavioral health services or maybe to a treatment facility, maybe in a community that doesn't have a lot of resources and or is overburdened, as we talked about earlier, and doesn't have, the wait times to complete that referral are just getting longer and longer. So, this is when we have to try to think outside the box and try to get creative, and we can't just continue to say, well, we just have to wait, or this system is broken and this is just too hard. We obviously have to provide a solution to serve our patients. And so maybe I would think about trying to take advantage of some of the telehealth options that are becoming more increasingly available and increasingly billable. And, if I'm in a rural community with a lack of behavioral health access or the timeframes are too long, maybe I'd think about partnering with somebody from Seattle, with an organization, maybe develop a memorandum of agreement or memorandum of understanding and embed a telehealth provider for 1 day a week or 2 days a week or whatever is financially feasible for the clinic. Explore ideas like that is what we'd probably put some effort toward.
Yeah. Okay. So I think we can close this word cloud and go to our next one, the resources that we need to remove barriers. So please enter the resources you need as an individual within your organization or your organization entire to really address those barriers you thought about and entered previously.
We're going to continue to leave this up. And here again, we invite you to enter your reactions or thoughts to what you're seeing in our word cloud into the chat box in Zoom, and invite anyone, if you would like to speak, let us know in the chat box. If you'd like to ask a specific question or share an idea, we welcome that. Hopefully we'll have better luck than we did with Gail in getting you unmuted, but we can certainly give it a try as we have some extra time now. And then again, here is where I ask you to think about what I talked about in that podcast earlier, throw out old ideas, think outside the box. What could you potentially bring in some innovative ideas? Dream big.
I like that time is the largest, and for me, money and time are very interrelated here.
I like improved reimbursement. I think that a lot of people would like to do more than they currently do, but it's not financially sound for them.
In the chat, I'm seeing sustained funding for clinical planning toward expected outcomes.
Any other thoughts or questions that people might have about some of what they're seeing up on the screen?
I think a piece in developing this broader learning community is really helping one another, but also advocating and learning how to make connections and then speak with one voice about these being really needed pieces to make our whole system function better. And we started the day by thinking about what 2020 has meant to all of us, how we think our pandemic has impacted behavioral health. And we're seeing here that resources, time, money, data, staff, that's really the barrier. And I know at BRE we really worry about burdening this system that already was so stressed, and really seeing the importance of kind of stepping back and figuring out how we can do it better. So appreciate your indulging our word clouds throughout the day and throughout our day 1 and day 2 of the summit.
So continue to participate in this word cloud and then enter in any thoughts you have or responses you have to what you're seeing in the word cloud. And now we also invite you to complete that last question, thinking about the people you may need to achieve your ideal state. We're not going to do a word cloud around that because I think that would be too confusing for everybody. But do think about that as you bring this idea or these thoughts back to your organization. Really think about every layer of your priority area and who will be impacted and who needs to be in that conversation to bring that goal to life. And then we'll ask you to complete the bottom box action plan on the bottom of the worksheet. Try to be somewhat specific in terms of timelines and what you may be measuring, depending on your goal. I recommend think in terms of, like Rachel said earlier, their goal was to improve naloxone prescribing by 20% rather than picking out a specific number, so improve by percentages. Then think about how long it might take. Think about your end goal and who this action is truly going to benefit. So we'll give you a few minutes to think about that and write down your thoughts there. Time's still a big one on that. So I am going to lock this one about barriers in just a second. Hopefully you're continuing to think about developing some sort of concrete action step around your priority area. So ready, I'm going to lock it in about 10 seconds. Okay. And then as you're putting in the action plan, as you're completing that last step of your worksheet, we'd love for you to share some of what you are putting down on your worksheet in terms of your concrete actionable steps within your organization. And we'd love for you to share them in our last word, well, almost our last word cloud, but the last word cloud for this activity. And remember for this one that you need to use a hyphen in between words. Otherwise they will be separated out in the word cloud. Okay, I think this should be open now on your phones or whatever device you're using. So we'll continue to give you time to work on that last piece of your worksheet, and then we invite you to share thoughts up on our last action plan word cloud. Ooh, eliminate unnecessary meetings. Research, I love that. Survey partners, I'd be curious if whoever entered that, if they'd be willing to enter into the chat a little bit more about that. I'm just interested in what that means. Does it mean, are you an MCO wanting to survey your clinics? Who are the partners in that action plan? Educate PCPs about mental health. That's a great goal. EMR integration, good one.
So I'm seeing in the chat, Megan, from an MCH entered survey partners, and they're working towards trauma-informed care learning cohorts for partners, but need additional clarity on how to create those cohorts to be effective and relevant.
That is a lofty goal and an important goal, and that will take some time for sure.
Yeah. Okay. Well, thank you all for engaging with our summit and for doing our series of word clouds. Amy and I are big fans of these, and it helps us process to see the dynamic words and to interact with them and to have others interact with ideas too, and to see some of those emphasized over others. I think that's very powerful, and we're all having to be very flexible in how we do our jobs and in how we do our lives, and that will probably be true throughout this year and into the next as our state and our country move through this pandemic. So I do want to step back and think about this goal of whole person health and really acknowledge that many of you have been working towards this goal for your entire careers. And we really ask that our collaborative, our BRE collaborative, be a partner, be a cheerleader, and be a supporter of the work that you all are doing. So today we've heard about screening, brief intervention, referral to treatment. We've heard about suicide care and treatment for opioid use disorder. We went through our exercise to develop action plans individually for organizations and discussed a bit about reimbursement for integrated behavioral health. So I would ask that you hold a space in your minds to continue this work. And we will be holding what we're going to call office hours in August to really hold people accountable for making the changes and to following through with the intent around the action plans that you all spent so much mental energy on today. I'll direct you to our website for more resources for recording of our webinars and through a forum through which you can ask and answer questions about this transformative work. So we will be in touch. Look out for resources from us. And I will wish you all health and resilience as we move into the second part of 2020. We're hoping for less stress, more community, and really a movement for true integration. And thank you all for your time today. And again, if you are interested in learning more about motivational interviewing, please join us tomorrow at noon for our webinar on that topic in SBIRT. Okay, thank you all.
Thanks, everyone.